डॉक्टर फारूक, तुमच्या स्क्रीनवर खाली मायक्रोफोनचं म्यूट म्हणून बटन आहे बघा, ते म्यूट बटन दाबा.
Thank you, Shyam. Good evening, dear friends. Greetings from Maharashtra Orthopaedic Association. Once again, I, Dr. Ajit Shinde, President of Maharashtra Orthopaedic Association, welcome you all in this wonderful masterclass series, Foot and Ankle session, which has witnessed elaborate academic discussion involving great teachers. Friends, academics have been always the priority for Maharashtra Orthopaedic Association, and our goal is to take the advanced knowledge and skill to the utmost peripheral level. I feel proud to share with you that MOA has become accredited to Maharashtra Medical Council, and we will be conducting many such webinar programs in future carrying MMC credit points. So I urge all the members and viewers to participate in maximum number and enjoy the academics. Today, for this brand new episode of present series, Common Problems of Foot and Ankle, we have with us the most experienced and senior orthopedician as a brilliant panel of faculties. Dr. Milind Pimparkar, senior orthopedician from Nashik with a great deal of experience. Dr. Narayan Karne is today not attending because of some health problem. Dr. Pradeep Munot, a renowned consultant practicing in Mumbai with advanced knowledge and vast experience from UK itself. Dr. Vaishali Dhumre Patil, an expert radiologist in the field. Dr. Praveen Patil, Dr. Akshay Zodge, Dr. Bhavan Pagar, and lastly, Dr. Farooq Khan. Many times we tend to overlook common ankle and foot injuries, many of which are innocuous at presentation, but if neglected can lead to adverse consequences requiring complex surgical management. Hence, all of us should be well aware of such conditions, which we are bound to observe in our daily outpatient department. Quite frequently and without knowing the nature of injury, it becomes difficult to decide the resultant treatment plan eventually. So to solve this issue, let's hear about all such injuries today from the experts themselves. Thus, I hand over the proceeding to my friend, eminent foot and ankle surgeon, Dr. Sampat Dhumre Patil and Dr. Abhishek Krimi. We are very much thankful to OrthoTV for kind cooperation, Dr. Shyam and Dr. Bislani. Thank you. Thank you very much. Jai Hind, Jai Maharashtra, Jai Amar.
Thank you so much, sir. And under your leadership, you have taken great initiative along with all the MOA members, executive members, and have provided a great platform for academic activity. We will start with our program today. Dr. Vache is going to talk a little later. So may I request?
Excuse me.
Yes, sir. Yes.
One thing I forgotten to tell, today's our program is sponsored by Johnson & Johnson. I am also thankful to them.
Sure, sir. So little change, Dr. Vache is going to talk a little later on pain management. May I request Dr. Milind Pimparkar, sir, to share his talk on ankle sprains. Over to you, Milind, sir. Milind, sir, has great interest in treating sports injuries, and we will definitely like to hear from him, sir. Over to you, sir.
President MOA, are you able to hear me?
Yes, sir.
Absolutely.
Right. So respected President MOA, very esteemed moderators for today's session, Sampath, Abhishek, and Ashok Sham, and rest of the faculties. My talk for today is acute ankle sprains, diagnosis and management. To begin with, ankle sprain is such a common problem which is encountered by all of us in our day-to-day practice, and is also encountered not only by specialized foot and ankle surgeons, but almost every orthopedic surgeon, and forms one of the most commonest entities in the orthopedic OPD. This vast topic, if one has to really cover in 8 minutes, will become a little difficult. So please allow me to shoot by a minute or two, if at all I need. So, acute ankle sprains, they account for about 80% of all ankle injuries, and 77% of these 80% are lateral ankle sprains. 73% of the lateral ankle sprains are due to either ATFL or CFL injury. In sports injuries, ankle is the most traumatized joint, and it accounts for 10 to 30% of all sporting injuries. In an epidemiological study, which was conducted from 1977 to 2005, which involved 70 sports in 38 countries, 32,509 ankle injuries were included, out of which 11,847 were ankle sprains. So that tells us about the magnitude of this problem which we face in our day-to-day practice. Acute ankle sprains are usually managed conservatively and by functional rehabilitation. So we are going to stress more on functional rehabilitation today. Failure of conservative treatment leads to development of chronic ankle instability, and which most often will require a surgical intervention. Thus, enhancing the in-depth knowledge of the ankle anatomy, biomechanics, and pathology will help us greatly in deciding the management options. The incidence of this injury, as we talked about, isolated ATFL injury accounts for about 66% of the ankle sprains, and further 20% are also associated with the CFL injury. The injury to PTFL is uncommon, as it needs excessive force with the ankle in dorsiflexion, which we will see when we come to the pathomechanics of this injury. Ankle sprains are usually classified as simple ankle sprain, but it is a misnomer. But there's nothing like simple ankle sprain. All ankle sprains one needs to really view with due seriousness. So simple ankle sprain, instead of calling it as a simple ankle sprain, we should call this as lateral ankle sprain. And the second is a syndesmotic injury, which is also called as high ankle sprain. Differentiating this lateral ankle sprain and syndesmotic injury are very, very essential in every patient of lateral ankle sprain you see, as it has a longer recovery time than other ankle injuries, and return to play may be considerably delayed. So pathomechanics, if you see, the foot, when it is forced into inversion and the foot is in a plantar flexed position, is the time that you get an ankle sprain. So that's the animation where you see the ankle is in the plantar flexed position and it goes into inversion. ATFL being the weakest, it gives way first. And if the same force continues, CFL is the second one to give way, which is followed by PTFL injury. So if you see the dissections, you will see that that is the arrow is the ATFL, that's the fibula, and that's the CFL. So CFL forms an obtuse angle with the ATFL where it gets attached onto the calcaneum. Injury mechanism, it's, as we said, inversion of the ankle in a plantar flexed position. And if there is an additional external rotation force coming into play, then it's a common mechanism for a syndesmotic sprain, which you can see here. That's the normal ankle mortise. This is the tibia, this is the fibula, and that's the talus. So once it starts tilting into inversion, and if suppose this goes into external rotation, this will produce a shear force on the distal tib fib joint, and that will give rise to what is called as a syndesmotic injury. When a high magnitude of this external force is applied, there is separation of the distal tibia and fibula, causing a syndesmotic injury, along with sometimes having a shear onto the intraosseous membrane as well. So that's the typical injury mechanism. You can see in the video, there's a Rafael Nadal. Have a look at the right ankle. Now the ankle is getting plantar flexed. He's landing awkwardly onto the ankle. And as the force moves forward, into an external rotation kind of mechanism, you'll see the foot getting inverted and then completing what is called as lateral ankle sprain. So that's the typical mechanism of injury which we see, or which the patient would probably tell us at the time of presentation. And such a force in day-to-day sporting activities is experienced when an athlete rapidly pivots internally on an externally rotated plantar flexed foot. So what is important is a plantar flexed foot planted on the ground and external rotation force. There could be contact with another player applying a valgus load onto a planted foot, or there can be a direct contact injury laterally on the heel with an externally rotated ankle. Risk factors. So wherever we talk of sports injuries, we have got to understand the risk factors associated with the sporting injury, and they are classified as extrinsic or intrinsic. The extrinsic factors, they include errors in training, maybe long playing hours, the level of competition where the athlete is competing, the equipment used, and the environmental factors. Whereas the intrinsic factors are innate to an athlete, which may account because of mechanical malalignment, ligament laxity, restricted range of motion at the ankle, and the decreased strength. So in any ligament injury, we find these are the intrinsic factors which will come into play. Similarly so in ankle sprains. More importantly, the previous history of ankle sprain would help us understand the injury better, as the incidence of recurrent ankle sprains is as high as 41%. And that is the reason why at the initial presentation, a first-time ankle sprain should be treated very meticulously, and they should go into a prevention program to reduce this incidence. If we consider a differential diagnosis, then ankle sprain needs to be differentiated from a Weber type B or C fractures, injury to the deltoid ligament, Masonova fracture, and a syndesmotic ankle sprain. With ankle sprain, there are certain associated injuries which take place, like bony contusions, osteochondral injuries of the talus or the inferior tib-fib joint, latent syndesmotic instability, impingement of ATFL because of heterotopic ossification, and osteochondral fractures of the distal tibia, fibula, or the talar dome. So these all injuries need to be addressed and looked for whenever you see a patient of lateral ankle sprain. When a patient comes to you to the clinic, the clinical examination should be performed in standing as well as sitting position. In standing position, one needs to observe for the gait. One might have an antalgic gait. There could be foot pronation. Tiptoe walking needs to be looked for. And you can also see for the areas of bruises or discolorations, which are very commonly associated with such ankle sprains. In sitting position, typically the patient sits on the examination couch with the knees hanging and bend at 90 degrees. And one needs to have a systematic way to palpate the bony points, which are like palpating the tip of the fibula, the medial malleolus, the ATFL, the CFL, and the peroneal tendons. The active and passive range of motion also needs to be recorded at this point of time. There are certain special tests which we do for diagnosing the ankle instability of these injuries. In an acute setting, they may not be possible because of the pain, but when it is chronic, these are the special tests, out of which the first two tests are done for a lateral ankle sprain, whereas the next two, that's the squeeze test and the external rotation test, they are done for the syndesmotic injury. Squeeze test is a very typical test where the examiner squeezes the mid-calf region and he tries to squeeze the tibia and fibula together. If there is a pain which is at the distal tibio-fibula joint, that talks about a syndesmotic injury. Sometimes the pain can ascend proximally into the tibia-fibular interosseous space, and that would probably indicate the extent of the interosseous membrane damage. External rotation test is by far the most important test, which is done with the examiner's palm holding the foot and ankle of the patient, and then forcing the ankle into dorsiflexion and external rotation. And pain at the tib-fib joint will suggest the syndesmotic injury. Although these are the clinical signs, the inter-rater reliability of these signs is very, very low. As you can see here, it ranges right from 87% to 100%. And that is why none of the clinical tests are by and large supposed to be conclusive in this kind of situation. There is another taping test which is done for the syndesmosis stabilization test, very important and good test, where athletic tape about 3.8 centimeters is applied onto the syndesmotic area here, and the patient is asked to perform activities like walking or running, if the symptoms of the pain or if the symptoms of the patient are reduced because of the taping, then one can conclude that the patient has got a syndesmotic injury. So algorithm wise, if you see the anterior draw test and inversion test, if they are positive, then probably it's a lateral ligament complex or ATFL injury, and that goes on to treatment like lateral ankle sprain. Whereas if you have squeeze test and external rotation test positive, then it talks about syndesmotic injury. And then there are certain further tests which we do, like fibular translation and Cotton's test, which will tell you whether it is a syndesmotic injury or a high ankle sprain. And accordingly, the treatment might differ a bit in these situations. We must also remember the Ottawa rules for getting the x-rays done, which are the investigation, and that is what I was talking to you about. The posterior aspect of 6 centimeters of the distal fibula and the distal tibia needs to be palpated for any bony tenderness. Along with this, if you have tenderness over a base 5th metatarsal or onto the navicular, then these bony tenderness would dictate you to get the x-rays done for these patients. If you don't have this, I, in my usual practice, do not get the X-ray done until and unless the patient actually demands for it, because most of the times, until and unless you get the X-ray done, the patients usually are not satisfied. MRI comes to me after 10 weeks of treatment. If after 10 weeks of conservative treatment and rehab, the patient is not stabilizing, there is edema at the end of the day, there is swelling, and there is pain at the end of the day, then usually I get the MRI done to see for the associated injuries as well. Otherwise, MRI is not a rule. A typical clinical picture would involve like this, where you find swelling at the ATFL, the lateral malleolus looks swollen. Sometimes you might get ecchymotic patches onto the lateral aspect of the ankle. This is a typical ankle mortise view. When you should do a mortise view, which is done in an AP projection with about 20 to 25 degrees of internal rotation. And what you look for is the clear spaces. This is the medial clear space. In a normal mortise view, the medial clear space and the superior clear space should be equal. But when you see that the medial clear space is more than 4 millimeters, then it suggests the lateral translation of the talus. As well as when you see the distance between the tibia and fibula, it should be less than 5 millimeters. If it is more than 5 millimeters or this overlap is less than 41%, then this talks about the syndesmotic injury or the distal tib fib joint disruption. There is another X-ray which we do in chronic cases, which is called as talar tilt. So you put the ankle into inversion and get the AP projection done. If this angle is more than 15%, then probably the patient has got a complete ATFL grade 3 tear. So what happens to the management of these patients? So the management is essentially conservative, and rehabilitation is the key. There are excellent surgical success rates when operated earlier, but then there is no consensus as to on the early stabilization of these injuries, as outcomes of conservative as well as surgical treatments are almost the same. So rehab for lateral ankle sprain and syndesmotic injury is the same. So these two injuries, even if you have diagnosed them, normally the rehab takes place in the same way for both the injuries. In literature, different rehab programs are either there is some noise coming. Is that okay? I can continue, right?
Please continue.
Yeah. So there are different rehab programs in literature, which are either 3-phase or a 4-phase program. And these programs are either based on a time criteria or they are based on criteria for progression. So conservative management, we have been following a 3-phase program at our center, and our protocol is a 3-phase one, where phase 1 is 5 to 7 days, which is typically the inflammatory phase of the tissue healing. And initially we start with the pain reduction measures, weight bearing to tolerance, and rigid ankle taping with lateral reinforcement. We have changed, or the world has changed, from price to police. Price used to be protection, rest, ice, compression, elevation. But nowadays we have to look at this OL, and that is optimal loading. So when it comes to ligament injuries, what we need to do is to start early weight bearing. And early weight bearing has shown wonderful results as regards the ankle injuries are concerned. We as an arthroscopy surgeons know that all ligament injuries previously were immobilized, but now the world has changed towards early mobilization, early weight bearing, and optimal loading. So optimal loading has got good effects on ligament healing, and similarly holds true with the lateral ankle sprains. So protection remains, optimal loading starts as soon as possible with pain reduction measures, that is weight bearing to tolerance. Then ice cold compresses and elevation remains the same. Once you have a satisfactory progression in phase 1, the phase 2 starts from either 5th or 7th day to 21 days. And this is called as proliferative phase of healing. The progression criteria is the pain is under control, the patient is able to bear the weight and walk without support, has got a near full active ROM, and there is reduction in the swelling. So in phase 2, the goals which we want to achieve is to normalize the joint mobility, improve the strength, and improve the neuromuscular control, and have activities of daily living going. Neuromuscular control is the most important factor here. And in all ligament injury rehabs nowadays, there is more focus onto a neuromuscular control as a whole and kinetic chain so that we can have better results. The mobility, it should be a low load and long duration exercises which the patient is put on. For example, stretching with cords, joint mobilization maneuvers, cycle ergometer to maintain the cardio fitness of an athlete or the patient, and repetitive range of motion exercises. Aquatic exercises are suggested by some people, but we do not have facility for aquatic exercises at our place. The strength training can be done with cords, bands, ankle weights, heel raises, step ups and step downs, calf press, isotonic exercises, and again neuromuscular training. The neuromuscular training talks about the proprioceptory exercises where we use progressive use of air cushions, wobble boards, those are unstable surfaces, airfield domes like Bosu balls, trampolines, and other perturbation exercises onto surfaces, different surfaces. So judicious use of bands, as you can see here, if you see this lady is using, that's R center, this lady is using TheraBands and she's trying to do isotonic exercises with TheraBands. So these are strengthening exercises which we do. That's again a Bosu ball and that's an unstable surface. So 3 unstable surfaces and his patient is trying to hold the core. So core building is another important thing which we need to do in all the patients of lower extremity exercises, and that talks about the kinetic chain. That's again an exercise for proprioception or balance or neuromuscular training, where a patient is standing on an unstable Bosu ball and is trying to maintain a bipedal stance. You can progress this to a single leg stance, which I'll show you in the next slides. So that's calf raises. Now calf raises are begun as soon as the patient crosses the phase 1. To maintain the cardio, this is another thing which one can do, and you can do it at any age. And this is an old man which is standing stable and doing a battle rope. So this battle rope, cycle ergometer, or other exercises are done to maintain the cardio fitness while the patient is undergoing an injury rehab. You progress, the progression criteria to phase 3 is when the patient can jog or hop with minimal discomfort. Once you achieve this stage, then you go to stage 3, but there are certain pearls which we have to remember in phase 2. That is, during exercises, you should avoid forceful external rotation and dorsiflexion. The exercises should be low load, longer duration stretching, which promotes the tissue creep. Joint mobilization using bands, towels, body weight exercises, strengthening using heel raises, forward and lateral stepping exercises are done in phase 2. The exercise is dosed with lower weights and higher repetitions early in the phase. Progressing to higher intensity, low repetition sets are directed at increasing the strength and the muscular size in the rehab process. So these are certain neuromuscular training exercises. You can see bipedal stance on an unstable surface. This is a single leg stance on a foam. This is again a single leg stance on a wobble board. And there you can see the cords being used as a resistance training. This is a double leg stance on a more unstable surface. That's a reverse Bosu ball. And this is a rebouncer or a rebound board. If you don't have a rebound board, you can use a mini trampoline, which is kept in this position. And the patient stands on a single leg, maintaining balance so that the core is also activated. So neuromuscular training forms one of the most important things in ankle rehab. Phase 3 is the maturation phase, which is from 21 to 42 days. And the goal is to prepare for return to play. The strength training is advanced and plyometrics is added. The perturbation exercises are added to the neuromuscular training. So this is here you can see that is a perturbation. Now here the athlete is being perturbed by a trainer from behind, and the athlete is trying to touch the codes. So that gives rise to a speed, resistance, perturbation, as well as the precision training before you get back to sports. This is another way to develop strength in these athletes. These are called as tire workouts. So this is again a strength training which an athlete goes on to when the athlete passes to the next phase of rehab program. So in phase 3, there are certain functional and agility drills which involves running, jumping rope, hopping, shuffling, karaoke exercises, figure of 8 running, and we can use props like cones, ladders, or hurdles. And then you come to sports specific drills as to if suppose he's a basketball player, then dribbling with the ball, soccer, then again dribbling, figure of 8 running, then running reception patterns, then shooting ball. So these are sports specific drills which we ask the patients to do. So there you can see that's the code, and the patient has to run across the codes. So that's figure of 8 running, which we call as. That's a ladder which is being used in a repetitive fashion to develop the agility. Now this is the plyometric. If you see this plyometric is really difficult to do, but then that is the way. And then you have a monkey bar, then the athlete lands and does a duck waddle. So this is a plyometric training which the movements, the quality of movement needs to be judged. The balance and the neuromuscular facilitation needs to be judged in these patients. If you see, this is again one of the strength trainings. This is called as a hammer workout. That's a step up, step down, which she's doing. And this is the side stepping. So these are all exercises which the patients are put on once they have crossed the phase 2 of rehabilitation program. This is the way you saw. That's again the same tire workout for the strength and conditioning. Return to play usually is after 6 months post injury, when an athlete is able to perform all the tasks at the game speed without any discomfort, and the quality of movement is good. So you've got to look for all these factors before you clear an athlete for return to play. The tests for return to play are a Y balance excursion test, vertical jump, dorsiflexion lunge test, and agility T test. I will not go into the details as there is a physio who's going to deliver the talk on this. So once the conservative treatment is over and the patient is not able to go back, then what comes next is a surgical intervention. So this is a case. We talked about the MRI and I talked about the bone bruises. So you can see here there is a medial bone bruise there. There is a bone bruise onto the distal tibia. You can also see that there is a hyperintense shadow at the ATFL attachment at that point of time. So these all injuries need to be seen. Those are the tests which we do, which is a talocrural laxity test. It can be done in different positions. Normally it is done in sitting position with knee at 90 degrees. One hand stabilizes the tibia and this one pulls the calcaneum along with the foot anteriorly to give an anterior drawer. You should also look for the medial laxity and subtalar laxity. So that's how actually we have been doing our cases, and we normally do what is called as modified Brostrom procedure. And recently we have added internal brace, which usually is done in an open manner. So if you see, that's the way how ATFL and CFL runs. You scope the ankle prior to doing any intervention, and that's the way the ankle is kept. Then this is the arthroscopic picture which you get. And if you see here, that's the tibia fibula, and that's the fibula tip. So there you can see the fibular attachment of the ATFL, which is at 1 centimeter from the fibular tip. And if you trace the same ligament along with the anterior capsule onto the talus, you will see that there is a gutter there, and that's the talar attachment where you see it is very, very lax. And that's the ATFL attachment onto the talus. So those who are doing arthrobrostrums will take a stitch through this and plicate this to the distal fibula. So those are two attachments of the ATFL which we saw on arthroscopy. You should do an arthroscopy to rule out any osteochondral fractures. That is the surface marking, that is the incision, and you raise an osteoperiosteal flap from the distal fibula, which is about 1 centimeter there. And that's the procedure, how it goes. So that's the anterior drawer. It's a grossly unstable joint. I will go a little fast here to just show you that we take stitches through the osteoperiosteal flap in a double breasting manner. So that's the way it is double-breasted and suture. And then what you use for this is if I have little time, I can just finish off with this video. So those are two anchors which we use with the internal brace, which is a fiber tape. That's a 3.75 millimeters anchor. And you have to see to it that when you are putting this internal brace in, you do not jeopardize the joint by over tensioning or over tightening it. That is why you mark this knotless anchors, and then one anchor goes into the distal fibula and the second goes onto the attachment onto the talus, which is just juxta articular. The foot is held in dorsiflexion and eversion, and the final seating is done. So that's the way how it is done, and that's the immediate post-op stability which you get. That is the anchor which is being used. Sometimes you can even use an image intensifier to locate. Those are the anchors for double breasting onto the distal fibula which have been used. And this is the final picture where you see that is the ATFL and that is the CFL, which both have been corrected. And if you see the post-op X-ray, you can see a hole which is at an obtuse angle, which is a CFL hole for the suture for the knotless anchor. This I would have loved it to be here, but then this is little proximal. I've given the rise to reasonably good result. Post-op brace, normally we put this patient for 4 weeks in a slab and then use air cast brace like this for the further rehab program, which goes on for 3 months. So to conclude, there is nothing like simple ankle sprain. Do not immobilize the sprained ankles. Optimal loading and early mobility is the key. Conservative treatment is the choice. Surgery is indicated only in the refractive cases. Landing techniques should be practiced to avoid recurrence, and landing technique should be taught to an athlete to prevent the initial episodes of ankle sprains. Neuromuscular training is the most important aspect in treating lateral ankle sprains. I thank you for your attention.
Thank you so much, sir. It was absolutely precise and very loud and clear message to us and every one of us that most of the times it's a conservative treatment, but when we hear conservative treatment, days are gone when we should give cast, give rest, because all of us, we have seen issues with immobilization, and optimum loading is the key. So we have with us Dr. Pradeep Munot, Dr. Abhishek Kini. Any suggestions, any questions to Milind sir? And then we will take opinion of our physio friends as well. Abhishek sir?
I think sir actually told everything about it. Like, I don't think there's anything left. But I think I completely agree. Optimum loading, we have to move from rise or from price to police. And when indicated, do not shy away from repairing it. Though I don't use the internal brace for my own personal experience. But yes, it has a role in it. And I think people mobilize patients with internal brace day 2 and day 3 also. So, that's one of the biggest advantage of giving a patient that additional security, especially in hyperlax individual where the person's natural anatomy or natural collagen is slightly lax. I think, but all points extremely well put. And I think it's always pleasure to hear Milind sir talk.
Thank you.
So I purposely told Sampath sir that like Milind sir has sports medicine experience. I think we should get him to talk on this.
Fantastic.
Thanks for the opportunity.
Absolutely precise talk. Pradeep sir, any thoughts on the ankle sprain?
I just wanted to add or ask something to Dr. Milind sir.
Yeah.
As you mentioned in one of your slides that the syndesmotic stability or the syndesmotic sprains and the acute lateral ankle sprains are almost treated similarly. I don't think so that's a right message to put across to general orthopedic surgeon. I think we have to differentiate in the different types of syndesmotic instabilities as well. What is your take on that?
So as far as the rehab is concerned, I think rehab remains the same. So the progression criteria remain the same. The time frame remains the same. It's only that it's not that syndesmotic injuries need to be immobilized. The progression criteria once met, one needs to, and that's what the literature also states. The incidence of syndesmotic injuries is far too low than the lateral ankle sprains as well. The key point is to understand and recognize syndesmotic injury. You may be a little slow in your rehab while you deal with these patients, but otherwise I will stand by my statement, and literature also supports it, that the rehab protocol should remain the same.
Okay.
So the message should be that a general orthopedic surgeon should take early measures to send these patients to a rehab specialist. Instead of putting them in a slab and then treating them for 3 weeks, because more often than not, these patients, they come up with CRPS if they are immobilized for too long, and they take a lot of time to recover after that.
Absolutely, I agree. So the single word is functional rehabilitation. Functional rehabilitation, because we have seen, I never thought that in India CRPS will be common, but to my surprise, even 10-year boy, 15-year boy, we have seen in CRPS, and that is just because of the slab cast for 3 weeks, 4 weeks. So we should take help of our physio friends, and that's why we have invited 2 of them here. But I fully agree with you, sir. It's the optimum loading. And one thing, our for non-athletic patients, our as you said, lateral complex is common injury. So ask them not to sit cross-legged, because they do that, and then the healing occurs in stretched position. So one simple way, simple message to non-athlete people is don't go home and sit cross-legged, because they will take rest, but then they will sit cross-legged. So that is when again lateral complex is going to get stretched. So I fully agree with you, and that's absolutely correct explanation to that. Can I ask my physio friends, Dr. Praveen or Dr. Farooq, do we have anything from modality side? Sir has fantastically discussed about the core strengthening and rehab program. Anything you add in terms of some modalities of physio training?
Definitely in early healing process, definitely we can add up the laser therapy now just involved. And suppose if there is a stiffness of the post-operatively, then you can have the matrix therapy to improve the joint mobility. So that both machines will help definitely the faster recovery.
Thank you. Thank you so much.
Yeah. Thank you.
Abhishek, any questions onto this? Very interesting talk and very helpful for all of us, sir. We are absolutely happy that you brought up this point. Functional rehabilitation. Ankle sprain is very common, and invariably we see them that we give slab for 3 weeks and just forget. But anyone who goes home, I tell them that at home, if this is the end of bed, this is called a simulated weight bearing. We have developed our own protocol. I ask them, even if you don't want them to walk, but at least do simulated weight bearing. It is a simulation of weight bearing, but do that. Anyone who is immobilizing is going to land up in issues. So functional rehabilitation, great talk, sir. Yeah. What are your indication of early repair, sir? I mean, do you do in high-end athletes for early rehab, or you will follow the same protocol in high-end athletes?
100% times the same protocol. Surgery is kept reserved for only those who do not respond, because rehab time is the same.
Absolutely.
You know, so I feel that whether high-end athlete or whatever, what I might do is I might get the MRI a little early if it is a high-end athlete. Otherwise, the protocol remains the same.
Perfect. This is absolutely, again, loud and clear message. Shinde sir, you want to add up anything, or you want to ask anything, because very common topic, and sir has also keen interest.
A basic thing, sir has given the message that you should not apply the cast and immobilization. Otherwise, all general orthopedic surgeons are thinking for any sprain, particularly lateral compartment sprain, they are applying 3-week cast. This important message now everybody at least heard today is that we should not give the cast and we should start early weight bearing, the functional rehabilitation.
Thank you so much, sir. Milind sir, thank you so much. if you can spare time to be with us today, it will be great because we are going to discuss few things in next talks also. Thank you so much, sir.
Yeah, thank you. Thank you for the opportunity. I'll just go in, just do one phone call and come back.
Please.
Thank you
Thank
so
you.
much.
Thanks.
Thank you. Thank you. We go to the next talk by Dr. Pradeep Monoth on painful heel. Again, one of the common scenario. We again same way do it the way we treat ankle sprain. We dump them on a single entity like painful heel. But let us hear from him. How do we evaluate and how do we treat it? Over to you, Pradeep sir.
Thank you very much, Dr. Sampath, for inviting me to share on. So what I will be talking, it's quite a huge topic, and I was given only 8 minutes to talk on it. So I'm not going to talk on the treatment plan of it. The key thing is how do you approach a heel pain? So not, and that would be my main talk. Can you hear and see my slide?
Absolutely, sir.
Great. So, as I said, thanks once again for inviting me. So, not every heel pain is plantar fasciitis. That has to be made very loud and clear. There are a lot of conditions which mimic or which contribute to heel pain. And in the next 8 minutes, I will be talking and identifying how to identify clinically what would be your differential diagnosis. So, as a breakdown, what are the common sources of pain? If you break down by either tendons, neural tissues, and joints and bones. So, looking at the tendon side, plantar fascia we know is very common on the plantar heel side pain, and on the back of the heel you have Achilles tendon. But do not forget there is another tendon called the flexor hallucis longus. You have a tibialis posterior tendon and the peroneal tendons, which can mimic or give rise to a heel pain or a nearby pain. Neural tissues, you have, of course, the tarsal tunnel syndrome, entrapment of the plantar nerves, but again, spinal pathology, lower lumbar spine, sciatic nerve entrapment, or sural nerve entrapment can also give rise to heel pain. Coming to the bone and joints, calcaneum stress fracture is quite common, more common than you would think of it. So that can cause it. Old previous injuries, fractures of the calcaneum or hide foot fractures can give rise to heel pain. Of course, you have arthritis in the subtalar joint or the calcaneocuboid area or the talonavicular joint, and of course, infections as well. So these are the conditions which give rise to common conditions giving rise to heel pain. So how you define if you ever get a patient for heel pain? So either it's inferior on the plantar side heel pain, you have a posterior heel pain, either on the medial side or the lateral side. So these are by structure or the site of heel pain. So let's look at the common causes from the side point of view. So if you have a plantar heel pain, or the common sources, of course, you have a plantar fascia leading to plantar fasciitis. But do not forget, you have a compression of the medial or the lateral calcaneum nerve or the plantar nerves, you can give rise to that heel pain. Also, and a very important entity, which it's almost by eliminating other causes of heel pain, is the fat pad atrophy. And I've had few patients where the fat pad has been lost either because of repetitive trauma or acute trauma and giving rise to heel pain. Posterior heel pain, of course, the common sources are the Achilles tendon, and you can just have an isolated superficial calcaneum bursitis causing rise to heel pain. But other causes are stress fracture, posterior impingement or osteogonum, and calcaneum apophysis in adolescent. Less common sources is the sural nerve. On the medial side, you have the commonest causes are the tip post tenosynovitis or the tip post insertion. You have a pain like accessory navicular or apophysis in adolescent. The less common sources is FHL tenosynovitis, or you can have an abductor hallucis involvement, either an atrophy or a inflammation in the abductor hallucis. You can have a deltoid ligament or a spring ligament chronic injury or an acute injury giving rise to pain. Posterior tibial nerve or a tarsal tunnel syndrome where the tibial nerve is compressed. And on the bone side, you have a medial malleolus. You can have again a tumor infection or a bone trauma or inflammation, or not inflammation, but a stress fracture on the medial malleolus. I had a few patients on that as well. On the lateral side, you have lateral ligament injury, as commonly as discussed before, that can cause rise to pain. and sinus tarsi as well. Less common sources peroneal tenosynovitis, tumor metatarsal joint involvement like arthritis in that. Peroneus brevis insertion or apophysis of the base of the fifth metatarsal, especially in adolescents or after ankle sprains. So how do you assess these patients? So subjective assessment, you ask the questions, and the questions you're looking at is depending on the age of the patient, pain aggravators, the types of pain you have. Pain, is it along with which type of incident, red flags and others. So I'll go one by one. So what type of age of the patient you have? If you have young patient, the common cause is severe disease, and uncommon is a calcaneum stress fractures or the tumors. Middle-aged patient, you have, of course, plantar fasciitis and tendinopathy is the commonest cause. While if you have an older patient, you're looking at a tip post synovitis. What aggravates the pain is the next question. Like if you have mechanical causes, like the pain aggravated by running or walking, you're looking at insertional tendinopathy, especially pain which increases with activity. That indicates a paratendinitis or a stress reaction or a stress fracture. If you have a non-mechanical cause aggravating the pain, and especially pain at rest, you're looking at a neural causes as well. Or pain on rising after sitting is a hallmark of a tendinopathy. Was the onset of pain associated with an incident? Yes, like running footwear or a patient started to train for something, then you have tendinopathy or a stress fracture. If it is no, you're looking at an arthritic cause. Pain behavior, if you have morning pain and stiffness, again, plantar fasciitis, Achilles tendinopathy, a tenosynovitis or FHL, or if it takes a long time to warm up, you're looking at considering an inflammatory arthropathy cause. Night pain, is a typical of bone stress like a calcaneum stress fracture or looking at any other sinister causes. General health and red flag signs like you have night pain, you have loss of weight, night sweats, joint pain and swelling, looking at tumors, infections or inflammatory causes. Past history like repetitive ankle sprains lead to posterior impingement and sinus tarsi syndrome. If you have had fractures like calcaneum fracture, you need to know, you need to rule out arthritis. Other causes like if a patient complains with cramping or of calf and feet, you need to exclude vascular claudication type of pain, or could be an early indicator of a stress fracture. Neural symptoms like burning sensation, sharp pins or needles, you need to rule out tarsal tunnel syndrome, involvement of the posterior tibial nerve and the branches. Looking at an objective assessment of the patient, always on the inspection, look from the front, look from the behind, look for any swelling, abrasions or rashes, look at any swelling around the Achilles tendon, either at the insertion or proximal to it, any fullness around the tendon as well. Look at the deformity if he has pes cavus or flat foot and muscle wasting. Palpation, we'll just go through it in detail in slightly later slides as well. So just for example, if patient complains of pain either in the center of the heel on the medial side, this area, or even in the midfoot area, these are still telltale signs of plantar fasciitis. You have quite few patients who complain of pain on the middle part of on the arch of the foot, which is still plantar fasciitis. On the medial side, pain around this area, compression of the Baxter's nerve, which is at the junction of the medial and the plantar side. Right in the center, you have stress fracture on the medial and the plantar side, plantar fasciitis or heel pad atrophy. On the lateral side, again, peroneal tendinopathy or strigonum or posterior impingement. Around in the center, you have a stress fracture. Just below the tip of the fibula, you have a sinus tarsi syndrome. Look at the posterior side, proximal to the incision, almost an inch proximal to the insertion of the Achilles tendon, non-insertional tendinopathy. Around the tendon, just anterior to it, you have a retrocalcaneum bursitis. At the insertion of the Achilles tendon, you have insertional tendinopathy. Examine the tibialis posterior because that can be painful. Check for the peroneal tendons, especially if they're subluxing or not around the lateral malleolus. Ask the patient to do a single leg raise and a double leg raise, and especially if they're not able to do it, single leg raise, it could be a tendon rupture of the Achilles tendon or a tibialis posterior dysfunction. Special test you need to learn to do this is called as a squeeze test, where you're compressing heel, hold the heel on both your palms and squeeze it. And when you squeeze it, look at the face. And when you're squeezing it, look how painful it is. And patient will complain of, look at that. Hold on. When you're squeezing it, you can see how painful it is. Look how he winces on his eyes. That's a telltale sign of a stress fracture. Movement stress, learn to do how it is. So squeeze the calf and then check for the. So learn to do it on the normal side, see how the movement is there. And then on the abnormal side, there is no movement as well. And here you can also see there is a bulge present as well. So that was a patient of Achilles tendon rupture with tendinopathy. Posterior impingement and HL, you can do it in prone, where you compress the heel and plantar flex the whole foot. And you find that the patient complains of pain at the back of the ankle. And also here you're holding just behind the medial malleolus and the lateral side, and you squeeze it, and you're extending the great toe, and patient complains of pain at the back of the ankle. That's a telltale of FHL tenosynovitis. So clinical assessment remains the most important diagnostic goal. Other investigations are done to rule out things. So you're not doing these tests to confirm the diagnosis of plantar fasciitis. Let's be honest. Plain X-rays you're looking at to rule out some other pathologies, like if you're looking at infections or if you're looking at significant calcification at the posterior, not the plantar side. You can do an ultrasound, lab studies to start with, look at CBC, ESR, uric acid, and RA test. And then depending on the degree of symptoms and the time, from the time of symptoms, you can investigate it further. Examples, here you can see x-rays of both heel with a pain for the last 3 months. Look at that. There is a telltale sign that this is a stress fracture. Got an MRI done. Look at this line. She finally went on to heal well. This patient came from Bangladesh with painful heel, where almost for 6 months he was being treated as plantar fasciitis. But here you can see on the X-ray something is not right. Got an MRI done. Look at that. There was a calcaneum osteomyelitis present. This is an X-ray for complaining again of heel pain. But look at that. That's osteogonum as well. Again, patient with bilateral heel pain with a big lump present at the back, with a slight injury, giving way injury. And here you can see bilateral Achilles tendinopathy, and one side he has had a rupture. So heel pain, in summary, is usually of mechanical origin. The commonest causes. Most valuable approach to use a site of pain to narrow down the diagnosis. And imaging can assist, however, should not replace a clinician's assessment for heel pain. Thank you very much.
Thank you, Pradeep sir. Absolutely well said, because we usually dump everything under plantar fasciitis, and there are so many pathologies which you have discussed. How do we evaluate? And we don't expect to talk about treatment in those 8 minutes, but absolutely well done. Dr. Abhishek, Dr. Vache sir has joined. Any questions to Pradeep sir?
I think Sir has covered everything very nicely. Like it's a big topic to be done in 8 minutes. And absolute justice. At least diagnosing point was like absolutely well taken.
We are also going to talk on exercises. Pradeep sir, how much do you feel that it is only clinical evaluation and it is supported by other, as you have rightly mentioned? How much you are aggressive in...
Just give me 1 minute. I will just put a switch on the light. Sorry. So, it just went dark suddenly. Can you repeat that question, Sampath sir?
Yeah. So how much you feel that we should be clinically evaluating it and just supporting it with other investigations, because painful heel, once it starts, we can keep on investigating without coming to conclusion.
So it's very clear. So I have a slightly different practice, and I'm sure you do as well. We are almost tertiary foot and ankle. So I get patients who are already 4 months, 6 months down the line with heel pain. But as a general orthopedic surgeon, if a patient comes first time with heel pain for a few weeks, I would not investigate in any way. Clinical diagnosis and good history taking. And if they give a telltale sign, morning pain, morning stiffness gets better with few steps, barefoot walking is slightly more painful, all the telltale signs of plantar fasciitis, I would not investigate at all. give them treatment, give them stretching, give them exercises, mild anti-inflammatory, and carry on with them. Of course, if they are more than say 3 months down the line or they are not getting better, then I would start investigation, and simple investigation like blood test, uric acid, CBC, ESR, RA test. Then and accordingly grade up those things and see how they are reporting to your treatment plan. If in 2 weeks time, if you've started with exercise and they come back no relief at all, then in those patients I would start investigating it earlier. Otherwise, if they're getting better and they stop exercise and then they come back again, that means it's just they're not following your, they're not, compliance is an issue. And the same thing with Achilles tendinopathy as well.
Yeah, thank you, sir. This is a vital message that clinical evaluation should be just helped by other investigations.
One question to Pradeep, sir.
Yes.
Pradeep, sir, what is your choice of analgesics?
So I have been now almost switched on to ibuprofen because I think these patients, especially with heel pain, chronic heel pain, once you write a painkiller, they will just keep taking it. They may not come to you, but they will keep taking it. And I want to be making sure that I do not prescribe a very strong renal toxic or nephrotoxic painkiller. And I find ibuprofen is one of the probably the thing where people or safety measures where you can take for even 6 months and they are not nephrotoxic. And I'm quite happy with. So either piroxicam or ibuprofen. And there was a once a day dose, which is quite helpful.
Thank you, sir.
Because yours is the tertiary care center. The patient comes to you, he must have already taken all the analgesics. That's why I'm asking you, what is your preference?
No, so as I was saying, so if they have already done all that stuff and they're still like coming at 6 months, 9 months, then my investigation treatment or investigation plan is slightly different. But even somebody who comes with a plain plantar fascia, and also one thing which I have understood from my practice is the key thing is, as I tell all even my associates and my staff, a patient with heel pain will take half an hour of mine, while somebody maybe having a complex problem will take only 10 minutes. It's the dialogue between you and the patient, understanding and making sure they understand what is the pathology and devising a treatment plan. Like first thing in the morning, you get up, icing, exercises, wearing chappals at home, and then getting out of bed. These are very, very important things. They cannot be doing exercise after breakfast. They cannot be doing stretches after breakfast. You already lost the body. He or she is already having pain for 2 hours then.
Right.
And they will just switch your doctor.
Yeah. Pradeep sir, can we cut short it because we have only covered 2 talks in last 1 hour. We'll go to physiotherapy and again take questions if they are there on Pilfulil. We agree that this is a common scenario, but we'll need to stick to time now. May I request Dr. Praveen Patil, and when we are asking question, next speaker should share the screen so that we don't waste again time to share the screen. And Dr. Praveen Patil, can you share your screen for exercises on Pilfulil?
Okay, sir, I'm trying but I'm not getting my PPT.
Just share the share screen button and then you will see your desktop. We tried same way. There is a share screen button.
I have done, but I'm just.
So we will see that we stick to time and.
Sir, we can just go ahead next presenter till the time. I'll just do it.
Yeah. Shall we go to the next talk on Abhishek sir talk on stress fractures?
Yes, sir.
Please.
So I think give me a minute. So I'll be talking on stress fractures, and it's something that we see a lot in sports medicine, and quite a lot of my talk has been covered by Milind sir in his rehab. So I think I won't take much time. So we know that stress fractures or fatigue or insufficiency fractures are kind of due to normal load at high frequency, like an overuse injury, or it can be at a heavy load at a normal frequency, but not that high load enough to break the bone entirely, and heavy load at high frequency. So it can be a variation, but the load is not big enough to cause an acute fracture, but subacute, suboptimal loading. So overuse injuries has been documented since 1855. It's 80% in endurance sports, and we see almost 28% in knees and 21% in our foot and ankle. And as Milind sir pointed out, for any chronic problems, there can be extrinsic and intrinsic factors. So it's a big difference between like what we say, just do it and just did it and ending up in a fracture. So etiology can be intrinsic or extrinsic. Intrinsic factors can be alignment, limb length discrepancy, muscle imbalances, weaknesses, flexibility too much or too little, posture, foot shape, and movement during exercises. Sometimes like muscle tightness overloads the joint, and that adds to a cumulative load, like tight calves, tight quadriceps can kind of give them, like, you see bodybuilders having those flexed attitudes. That is not always good for fitness. Similarly, extrinsic factors can be shoes, the surface on which the patient runs or plays, sports gears, like especially if they're wearing tight stockings, environment like heat, what is the humidity level, and technical errors. So surface does matter, especially when it comes to overuse injuries. Like natural surfaces which are better shock absorbing, like grass, ground, gravel, and sand, are much more forgiving onto our bone and joints than synthetic surfaces like asphalt or tarmac or cement concrete roads on which patient runs. Similarly, the technique, the way we do our exercises, the way we run, our pattern, running load are important. So there is a wrong and the right way of doing it. So it's important that we kind of identify where our patients are going wrong to kind of ending up in these stress fractures. So faulty technique, again, where we hold the grip or where the patient's studs are in a football shoe are all important to kind of pick up certain things of faulty techniques and injuries. So next point, very important, where it predisposes to muscle cramping and muscle overload is dehydration. It's important that in an endurance sport, patient maintains his hydration. And as we see that as the hydration level drops, there are more and more chances of muscle and bone and joint injuries, because the recovery pattern takes a longer time for an athlete to get back to its normal resting level. So training principles depends on the type of sport that the patient is kind of playing in, intensity, the duration of which he kind of plays with, the frequency, and the recovery time that he gives to patients. So before we go on to what happens, we should kind of just touch up upon certain exercise principles. One is overload. Training effect occurs when the body part is worked harder than normal, and load has to increase as fitness increases. So any abnormal increase in load will kind of cause injuries, as well as no increase in load will not increase their fitness. So it's a kind of, it goes parallel, hand in hand. So specificity, effect of training is confined to systems that are overloaded. Like if you're cycling or if you're running, then your lower limb is involved. While you're playing tennis, then your shoulders are involved. So yoga increases flexibility and weight training improves strength. So there are kind of important things that have to kind of be combined, or cross training effects have to be brought in to kind of get proper fitness. Adaptation, so our human body adapts to certain type of stimuli. So weightlifting develops muscle, but hanging does not increase height. So it's important that you kind of adapt to your load and your sport demands. Similarly, detraining, so effects of training are not permanent, and strength is lost at 0.3 to 0.1% every week. So if you stop training, your muscles are going to drop your strength and tone. So it's important. So coming back to your overuse injuries, it can happen due to training errors, anatomic factors, shoes and surfaces. And we know that every body part can be kind of affected in stress fractures, especially in our lower limbs, the tibia or shin splints or medial periostitis to any of our tarsal bones or metatarsal shafts can kind of lead to stress fractures. So stress fracture theories are fatigue theory where muscles give up and load directly onto the skeleton, or overload theory where muscle contraction results in bone bending and overloading on their side, on the side of contraction or side of force application. So all are vulnerable, like weekend warriors to elite athletes, and even our god of cricket is not spared and he had a stress fracture. So stress fracture location can be metatarsals, fibula, tibia, calcaneum, navicular, or femur, pelvis, humerus, or even the stress fractures of the vertebral bones. We had a diagnostic dilemma where he had a kind of a metatarsal or sesamoid overload, and we had to dilemma whether to inject, or there were certain suggestions to exercise, but it was well managed with customized orthotics and video analysis. So how do you diagnose stress fractures? The best thing to do it is radioisotope bone scan. It kind of picks up a hot spot. MRIs will also show a lot of bone marrow edema pattern, and sometimes X-rays will show exuberant callus formation over there, as you've seen on the right side image. Symptoms can be insidious or acute. You have to suspect a fracture, and treatment is active rest. As Milind sir pointed out in foot and ankle, to kind of overcome CRPS, we need optimal loading pattern. So training surfaces have to be analyzed, whether it is too hard or too soft, whether the running is happening at an inclination or slope running artificial. There is a long leg and a short leg stance that happens. Uphill stresses the tendoachilles, which can kind of stress the calcaneal insertion, and downhill running can kind of load the quadriceps and load the patellofemoral joint. So you need to consider sport when you're looking at surfaces, and check for stability and shock absorption, especially when you're looking for shoes. Orthotics may be required according to the foot anatomy, like whether it's plano-valgoid or high arch. You come for footwear selection, buy the shoe at the end of the day, because due to gravity, the foot size increases by 0.5. You need to consider weight, consider the sole of the shoe, the upper, the heels, the heel counter, and the lacing pattern depending on the sport that you're involved in. And also take care of the environment that you're running or participating in the sport because of sweating. And it's important that the shoe fabric breathes, otherwise you may get other associated complications. Training versus training is something that you need to emphasize. The old dictum that no pain, no gain does not always stand true, and you need to practice correct posture, as practice makes a man and a woman perfect. So key principle of exercise is overload, but there is a fine line between sensible exercises and going overboard. So that needs to be emphasized by you and your rehab team. And it's important to have a team of doctors. So you need to understand that the athlete or the sports person is a different animal. He hates the word rest, and he would rather come to you with wanting a fitness certificate than a leave certificate. And recovery needs to be optimized to get to pre-injury levels to be restored. So it's important that you have a good sports medicine team, like Milind Pimprikar just emphasized. You need a good physiologist, a good biomechanist, trainer, physio, nutritionist, a good psychologist, sports physician, and musculoskeletal radiologist, as we're going to have Bhuvan talk subsequently with us. And lastly, our role of surgeon being a little small role in this sports medicine team. So need to understand the physical and the mental aspects of the sport. Need not give complete rest, but give active rest. Do not rigidly immobilize, but give functional immobilization. And you need to prescribe the correct exercises rather than medicines in such problems. So preventing stress fractures, most important thing is sensible exercises and training. And you need to get your physios, getting them on their drawing boards and showing the patient or athlete what's going wrong, where his biokinetic chain is kind of faltering, because the strength of the chain lies in the strength of the weakest link. And sometimes you see that there is shin splints, but there might be a proximal pelvic tilt, which is kind of causing the entire biomechanics of that lower limb to load on the leg compartment more on the medial side than on the lateral side. So it's important that you do a proper functional assessment of the entire lower limb biomechanics before prescribing treatment. So that's important. Bring elements of cross training, as we involve different muscles, different joint, different environment, and it helps kind of overcome or strengthen lower limb biomechanics. And this is something that I tell, don't listen to trainers or group trainers where there is now herd mentality, and you need to listen to your own body. If your body is trying to tell you that this is hurting beyond, say, like a mileage of 10K or 15K, then you need to stop there and do not just follow group trainers kind of who get them to push them to 21, 25, 30Ks every weekends. So make sure that you listen to your own body. And current trends that are happening that are improved, as Milind sir showed in physiotherapy, is like what optimum loading is kind of overcome, then just rest. Subsequently, prevention of injured area, therapeutic exercises and sport specific exercises are now guided according to supervised therapist. And physiotherapy has changed from kind of electrotherapy or wax bath, where we have very little role of wax, and now gone in more in strengthening, core stability, functional training, and manual therapy, where they do releases and stretches. And the advent of new isokinetic devices for assessment of training have kind of helped us identify specific shortfalls, like how much is the external rotation deficit, how much is the glute strength deficit, how much is isolated quad like VMO or lateralis strength assessment is done, and those shortfalls are kind of overcome by isokinetic devices for assessment and training. So this is a very important tool in your sports management team approach, where you kind of deal with a lot of premier athletes, where you kind of treat them and help them overcome such chronic injuries. So once you kind of have an overall look, then I think you are all right, get set, all ready to get set and go. Thank you.
Thank you so much, Abhishek sir. Thank you so much. What I will do is I will share my screen first so that we save on to the time, and then we'll take questions onto your talk. Are you able to see my screen, sir?
Yes, sir.
Yeah. So any questions to Dr. Abhishek on shin splints or stress fractures? Milind sir, any suggestions, any questions to Dr.
Wonderful talk. I think almost all aspects were covered. The only thing which I wanted to add up is there are two types of investigations which we normally do. One is lab-based and second is field-based. So isokinetic testing usually would be a very far-fetched possibility for a common orthopedic surgeon or even elite orthopedic surgeon in most of the metros as well. So explosive exercises like for muscle testing, if you're testing lower limb muscles, so a sergeant jump or a vertical jump. So there are certain small things, like for example RTP criteria for ACL rehab. We do a single hop or a triple hop. So a balance, coordination. So I think these RTP criteria tests, which are field based, like Y excursion test, which tests the coordination and the balance, sergeant jump or a vertical jump to know the explosive strength in the lower limbs, then a medicine ball throw to judge the strength in the upper limbs. These are small certain things which we need to focus upon and talk about more, because isokinetic testing may not be available at every setup. So I think field-based tests like for VO2 max as well, field-based ones are probably the more practical ones. I think that's a wonderful talk, Abhishek.
Thank you, sir. I think I completely agree to your point. Isokinetic testing are, I think, luxury, I would rather put it. But the only advantage and the only reason why I put that last slide in my talk was to kind of it sometimes help you isolate or identify single muscle deficits, which sometimes all these tests that we do, like, RTP tests that we do, like single hop, triple hop, or vertical jumps and all, they are more of a complex muscle coordination. So once you've identified that, once your clinical assessment has identified a deficit which is happening in certain phases of your movement, then to isolate or to break that down further, these equipments can only be used. Absolutely. But unless you know your basics of complex, just having this is a strict no-no. I think then you are getting the whole picture of. I think you need to first identify your complex lower limb biokinetics right from your spine pelvis junction to your metatarsophalangeal joint, identify that whole link where you're falling short. And then once you identified in a certain group, then get onto the machine to identify, because then the machine also gives you a quantitative analysis where today he is at point A and you need to take him to point B. So it helps patient mental feedback in that way. But yes, it is an extreme luxury, not everywhere available. And again, you need to have a long learning curve to kind of master it also. And you cannot reach that level until you have mastered the basics, where the return to play sport comes in your, I would say, level 1 of getting this. Then only you have to go up to that level. I completely get your point. Thank you, sir.
Thank you, sir. One good point you talked about is listen to your pain. I mean, take the feedback of pain. That is, again, important thing which you talked about. So thank you so much. We'll go to the next talk, which I'm going to talk on X-rays and some views in foot and ankle. I'm going to talk on some of the weight-bearing X-rays. How do we take them? We have such little modified version of stand where we put on this cassette here in slots for foot AP, and this slot where we put on cassette for ankle AP lateral X-ray, which are standing. And see this is ankle AP view, where the opposite limb is on the above step, so that the patient is completely weight bearing, because both legs at the same level will not allow weight bearing. And same thing here, that on lateral, the other leg is on the up step. So it's a complete weight bearing view. Such views are very important whenever there is a whenever there is injury, transsyndesmotic fibula fracture, whether they are stable or not, to identify the stability of the joints, and look at this flat foot evaluation as well. These weight-bearing X-rays are very important for assessment of the angles as well. Sometimes non-weight-bearing X-rays, initially they appear quite normal. This X-ray was passed on to as normal, but see, there is a huge fibula fracture along with medial malleolus fracture, and you can even confirm it by some of the stress views. For posterior malleolus, obviously CT scan is very helpful, but if you take this external rotation lateral view, where the cassette is on lateral side and the X-ray source is on medial side, external rotation around 45 degree shows you posterior malleolus better, because then fibula overlap is taken care. This is gravity stress view, where the fibula is facing down. So you are hanging the foot with lateral side down, and you see if it is a transsyndesmotic fibula fracture, you see opening of the medial joint space. That will show you the unstable syndesmosis. This is just to evaluate, but don't take the X-ray like that. We will not expose this man. We use this chest stand to hold the cassette. So this is gravity stress view. And we see the widening of medial joint space. This is standing axial view, where you have angled the tube at 45 degree and patient is standing here. So this is from behind, standing axial view. So this is what it gives you the picture like, and this will give you angle of the hind foot and relation of hind foot to the leg, whether you are dealing with varus or valgus deformity. Stress views, yes, stress views are important. Like the last case we discussed about medial malleolus fracture, similarly, is a tip of fibula fracture. We are testing the stability of lateral structures, varus stress view. Axial view, everyone should know it, even intra-op and pre-op or post-op. How do we take this view? Again, 45 degree angle, and don't use hands to pull up the dorsiflex the foot. Use this kind of bandage or sterile bandage intra-op to make the dorsiflexion. So this is how these axial views should look like. And if you're taking Broaden's view, then same, but internally rotated. So just you have to internally rotate it and again pull it in dorsiflexion so that you have to see this subtalar joint. See, these are intraoperative views. This is axial view where nicely you can see the axial alignment, whether it is in varus or valgus. And this is Broaden's view where you see the alignment of the posterior facet nicely. So difference between this and Broaden's is just internal rotation, and then of course 10, 20, 30 degree of angle of the X-ray tube if you want. These are different views intraop. So axial and Broaden's views are very important. This is Broaden's view, very important to know the articular congruity of the subtalar joint. Canale view is important. How do we take it? Flex in the knee, then pronate and pronate the foot at least 15 degree, and your X-ray source has the angle of 75 degree, and you can see complete neck. This is for evaluation of the talus neck. Foot X-rays are very important. Again, standing X-rays, if it is possible, it is good. We take them this way. And always see in standing AP view, lateral border of first metatarsal should be in line with the lateral border of first cuneiform. Medial border of second metatarsal should be in line with medial border of second cuneiform. In oblique, medial border of third metatarsal to the medial border of third, and so with the fourth metatarsal as well. And also the lateral view one should see. Stress views, if you are suspecting Lisfranc injuries, then what you should do is stabilize the hind foot and abduct the forefoot and see whether these Lisfranc joints are concentric or not. So this is stable. This is not opening. This is not opening. So this is stable. So this is how we do intra-op also, or even pre-op, to know the instability of Lisfranc joints. Sigmoid view, do the same way. Just pull the toes, and then this is the X-ray source, and this is the cassette. You will see sigmoids like that. What Dr. Abhishek just showed you, the sigmoid view. Whenever we are dealing with some of the injuries, particularly midfoot, what we do, we order ankle AP lateral X-ray and foot AP oblique. But then this is a junctional area. This is not focused in foot view, neither this is focused in ankle view, because this is a junctional area and very likely that we miss it. See, this was a footballer where this injury was missed completely. These were passed on as a normal X-ray. See this was like that. This was a tenonavicular dislocation, but completely missed. Why we miss it? Because this is how the X-rays are given. Ankle AP lateral, they take it complete like this, but while giving, they give it this much only. So you ask your X-ray technician that give me X-ray like this, and then only you can know what is happening, where it is going wrong. So anyway, while shooting, they shoot this X-ray, but while giving, they crop up like this. So please see, there are maximum chances that you may miss the midfoot injury. One word about CT scan, because nobody is covering CT scan. Read your CT scan in your console yourself. Don't read the films. Why? Because see, again, there are chances that you will miss it, because every joint has different orientation. Midfoot has this orientation, ankle has this orientation, while your CT scan technician will always pass on the orientation of ankle to midfoot to calcaneum and this way. So that will not give you correct information. See this. Now, if I want to evaluate midfoot in this is the way they take, give the cuts. But how I want the cuts, those cuts should be like this. They should be parallel and perpendicular to the midfoot. Then only it will give me enough information. And then I will see on console myself, and then it will yield more information, because those films may not represent the complete evaluation of the joint. And this is coronal, this is sagittal. So you read yourself, and those axes can be changed intra yourself. See this is non-concentric joint. This is non-concentric joint. So you evaluate yourself. And of course 3D. But you see now, if you don't adjust the axis correctly, then this may not be picked up, all posterior malleolus. So to summarize, standing X-rays are important. Stress views are important. You should know the positions for spatial views, know the radiation hazards, and please read CT scan yourself unconcerned. Thank you so much. What I will do is, again, thank you, sir. Again, I will share the next talk is on ultrasound, and then if there are any questions, I will be happy to answer the questions. But without wasting time, I will hand over this laptop to my wife, who is going to talk on the role of ultrasound. Just give me a second, sir, because as I was talking, I was not prepared for her. Okay, so Abhishek sir, any questions till then? I'm just.
I think that's one of the reasons why I really felt while we were planning the talk that this X-ray should be taken by a foot and ankle surgeon, because I think we need to emphasize on how on plain radiographs we can analyze our deformities. That's important. That's importance of weight-bearing X-rays and all other things.
Yes.
I'd also like to thank Milind sir. I think he has to leave now. But
Yes.
Milind sir, thank you very much for your time. Really appreciate, and it's always a pleasure to just see you, but more importantly to hear and learn from you always.
Thank you. I'm just sharing the sonology talk, and we'll be talking on role of sonography.
I think we have ma'am covering up on sonography, and then we have Bhuvan, who's going to is a musculoskeletal radiologist from Bombay and other parts of Maharashtra, talking on MRI. So we have the entire radiology covered up today.
Yeah. Are you able to see the screen, sir?
Yes, we can, sir.
Yeah.
Okay, thank you, Abhishek. I think I'll take a leave. Thanks a lot. It was a wonderful session. I would have stayed back, but there is a little family emergency, so please forgive me.
Please take care.
Thank you once again.
Our pleasure. Our pleasure.
Thank you all.
Welcome, ma'am.
For inviting me. Yeah, thank you all. Good evening. Thank you all for inviting me to talk on the role of sonography in diagnosing the foot and ankle pathologies. We will straightway start the cases. This is the first case, 35 years old lady, where Lisfranc fixation has been done. And she was complaining of pain on the medial aspect of the foot on weight bearing. On X-rays, everything looked all right. But when we did ultrasound, we could see the tip of the screw, which was irritating the tibialis posterior tendon at its insertion. This is the tibialis posterior insertion, and this bright spot is the tip of the screw, which was irritating her tibialis posterior. So we discussed the case with the surgeon. The implant was removed and the patient became pain-free shortly. Ultrasound helps to know the pain generator. This is another case where trimalleolar fixation has been done. And patient was again complaining of paresthesia and pain on the medial aspect of the ankle. On ultrasound evaluation, there was, this is the posterior tibial nerve, which was getting compressed because of the posterior plate. In this case, the implant was removed and the pain was relieved shortly. So ultrasound is a very useful dynamic tool to trace the nerves around the implants, where MRI becomes impossible in some cases. This is 22-year-old boy who presented to us 6 weeks after the injury with a scar on his medial aspect of the foot and ankle. He was complaining of paresthesia on the medial and the plantar aspect of the foot. We did the ultrasound. You can very well see this nerve, which is medial plantar nerve. This now looks all right till here, and this black thing is the scar. This is the scar where the nerve is absolutely all right till here, and then it is embedded in the scar. The surgeon was interested in knowing whether the nerve is all right or it is injured because of while the injury. So we discussed the case with the surgeon. The nerve looked all right to me, and exploration was done. You can see this is the posterior tibial nerve. The medial tibial nerve, which was all right. neurolysis was done and the patient was relieved of his complaints. So ultrasound very well helps to the surgeon to localize the entrapment of the nerve if it is there. This is interesting case. The lady was just working in the garden and she developed a swelling on her medial aspect of the foot, and it was painful. We did the X-ray. X-ray was absolutely all right, but on ultrasound we saw a linear echogenic line, which was a foreign body where there was a pain. So this foreign body was removed. This is intraoperative picture where you can see the foreign body. And this is a very small foreign body which was diagnosed on the ultrasound, and this was removed. This is the foreign body. So the radiolucent, particularly the radiolucent foreign bodies which are not seen on the X-rays, can be very well localized, diagnosed on the ultrasound. This is tendo achalis. This is the normal side, right side. The tendo achalis looks very normal. And this is the left side. The patient was complaining of swelling and pain on his heel. On left heel. This is the tendo achalis, which is fusiform, degenerated and inflamed. You can see this is the right normal side and this is the left abnormal side. So ultrasound helps, many times helps to compare the pathological side with the normal side. This is an interesting case where 33 years old male was complaining of tingling on his medial aspect of the left foot, which was there since 2 to 3 months. There was no swelling on the ankle or the foot on clinical examination. When we scanned him, this is the posterior tibial nerve. This is the posterior tibial nerve, and there was a mass in the posterior tibial nerve, very well-defined hypoechoic mass in the posterior tibial nerve. Here you can see the nerve beautifully. All the nerve fibers are seen proximal and distal to the mass. This is at the level of the medial malleolus, where you can see the posterior tibial artery, the posterior tibial veins, and this is mass in the posterior tibial nerve. The case was discussed with the surgeon. Exploration has been done, and this is the mass which we were seeing on the ultrasound. This was removed in toto, and histopathological report confirmed it to be neurofibroma. So ultrasound helps us to trace the neural pathologies very well. Again, this is a 30 years old male patient who presented to us with snapping sensation on the lateral part aspect of the ankle. There was just history of twisting injury 2.5 years back. This is the peroneal tendon. This peroneal tendon looks absolutely all right on the right as well as left side. But now see the video. This is an interesting video where you can see that the peroneal tendons on dynamic movement, dorsiflexion and inversion of the ankle, it is getting dislocated anteriorly. See, these are the peroneal tendons. This is another video where you can see the peroneal tendons are getting dislocated anteriorly. So here also dynamic, the dynamic part of the ultrasound plays a very important role. These stress fractures can be diagnosed very nicely. This patient presented to us with pain on the dorsal aspect of the foot. The X-rays look all right, but on ultrasound, this is the third metatarsal. This is the long axis view, and there is a breach or break in the continuity of the cortex. Here is the break, which is suggestive of the stress fracture. This is another case of the shin splint. This patient was an athlete. She was a runner and developed pain on the shin. This is callus formation. This is again breach in the cortical continuity, which was suggestive of the stress fracture. So when X-rays are normal, this is a simple way to diagnose the shin splints as well as the stress fractures. This patient presented to us with swelling in the second web space. On ultrasound, we can see a very well-defined anechoic or the cystic mass in the second and the third metatarsal. On a color Doppler examination, this was a cystic mass and not a vascular mass. This was a simple ganglion cyst. So ultrasound basically helps us to differentiate between the cystic mass and the vascular lesions. This is EHL tendon. Ultrasound is very helpful to diagnose the tendon injuries or the tendon tears. This patient presented to us with the scar on the dorsal aspect of the foot with inability to dorsiflex the great toe. On ultrasound examination, this scar was absolutely healthy, but see, this is the EHL tendon. You can see the continuity till here, but here the tendon is completely torn and retracted. So this was complete EHL injury. It helps to diagnose the ultrasound, the tendon injuries. Again, this is Achilles tendon. This is the Achilles tendon, and you can see a big defect in the Achilles tendon. This is complete tear of the tendo Achilles. we can help the surgeon by giving the size of the defect, as well as we also help the surgeon to know the quality of the tendon, whether how it is to be treated conservatively or surgically. And this is the last case, 32 years old lady who presented to us with severe pain on the medial aspect of the ankle. There was history of injury on the medial side of the ankle. And see, this is the posterior tibialis posterior tendon. Till here it looks normal, but then here the tendon was grossly enlarged, edematous, swollen. On color Doppler examination, it showed significantly raised vascularity. Patient was treated conservatively. This is her first scan, and this is follow-up scan after 1 month starting the treatment. You can see how dramatic difference is there. This was highly inflamed, and this is 1 month after the treatment. The inflammation is all gone, and even the tendon has become near normal. So it helps us to know the follow-up evaluation of the patient. These are some of the probes which are very helpful in musculoskeletal ultrasound. These are high frequency hockey and the matrix probes, which are particularly useful to diagnose the musculoskeletal pathologies. So to sum up, ultrasound is an effective and very important mode of diagnostic modality to as it is very dynamic, economic tool. We can compare the pathological side with the normal side whenever it is required. Follow-up is easily possible, and we can detect the pain generator as we discussed. Whenever possible, we can do USG guided injections as well as interventions like aspiration and FNSs. Thank you.
Thank you, ma'am. I think you brought about most points absolutely perfectly.
Abhishek sir, we can invite the next speaker so that we don't waste time, and whatever questions for these two talks are there, we are happy to answer.
I think our next speaker is Bhavan. Bhavan Paunipagar is a musculoskeletal radiologist who's attached to multiple units. Like, he's a co-director of Akshay PET CT scan from Sangli and Kolhapur. And he's also a musculoskeletal radiologist at various NM Medical Center in Bombay and Pune. It's actually really great to have Bhavan here with us. It's a small world. We have a lot of common friends together. And Bhavan, without wasting much time, otherwise I will need most of your time introducing you rather than letting you talk. So please start, Bhavan.
Yes. Thank you very much, Abhishek. Am I audible?
Yes, clearly.
Yes. It's very interesting to be a part of this team, which is very subspecialized and very focused to deal with ankle and foot. And I appreciate the focused approaches, as well as I'm learning a lot when I'm listening to the speakers. When it comes to imaging of ankle and foot, what Dr. Vaishali told, I think absolutely correct, that ultrasound plays a very vital role, and MRI may be one of the investigation of choice when sometimes ultrasound may not be of helping nature. Let's see some cases. My cases are visible, right?
Yeah, very well.
Okay. So this is a 43-year-old patient who had licking pain, and there was a swelling around the first metatarsal bone. This is very self-explanatory, very much intermediate signal cystic component, which was enveloping the first metatarsal bone. And there was some internal heterogeneity which was appreciated. We could see on the blooming sequence, the susceptibility sequence, we could see that there were some concretions within that cystic component. Very obvious adventitial bursitis, very common, and this is a non-anatomic bursa. So it is because inflammation of that adventitial tissue because of trauma, infection, or say chronic inflammatory processes. Usual cause is the frictional wear and tear, which is at the pressure points. MRI does help in understanding the anatomy. Definitely, ultrasound plays a vital role when it comes to adventitial bursitis evaluation. Another case, patient with chronic foot pain and numbness. This is a coronal T1 and a PD fat set image. We are able to appreciate intermediate signal in the second web space. The same PD fat suppressed image showing a very dusky intermediate signal, or say a heterogeneous hyperintensity, which is appreciated in that web space. We did push contrast, and we could see that there was some contrast enhancement appreciated within. Very obvious that it was a Morton's neuroma, and because of perineural fibrosis, which is caused by the entrapment of the plantar digital nerve, this type of nodular thickenings, which appear teardrop, very classical teardrop type of lesions, and best seen on the coronal MR imaging. Definitely ultrasound would play a vital role in assessing this. Another patient, painless nodule in the plantar aspect of the foot. This is the sagittal PD and a T1 weighted image. We can see that on both the sequences, there is a nodule which is not showing any differential internal intensity, and this is located in the plantar fascia. This is the coronal image. We tried to push contrast, but it has a very variable type of enhancement within. Superficial plantar fibromatosis would be the best appropriate diagnosis fitting in that. This is because of the fibrous proliferation that would replace the area of that normal plantar fascia and would definitely take a nodular shape. To take it to a further extent, we saw another patient on similar notes having a large mass which was diffusely hypointense and very much deeply spread, and it was found in the plantar aspect of the foot. It didn't show much enhancement, but yes, there were some, I think because of pressure effects, there were some internal enhancements. We could appreciate it's very much deeply trying to spread into the entire foot, or say the deeper aspects of the plantar foot. Deep plantar fibromatosis was the histopathological diagnosis which was made. We initially had a doubt about having a giant cell tumors or some bit of those aggressive tumors, but based on the pattern, and then usually we don't expect the fibromatosis to enhance that much. The way in which it is enhancing, the suspicion was high towards relatively aggressive type of neoplasm, but it turned out to be a desmoplastic component, deep plantar fibromatosis. Another patient with a painless foot swelling since few years. This is a coronal image. Are we able to appreciate any mass in that entire image? Very difficult. I mean, for the first group, for a radiologist also, it was very difficult that there was some mass somewhere around here. A fat suppressed image, very well depicting that presence of a hyperintense mass, which was within the plantar muscles. This was that entire mass, which was seen quite well on a fat suppressed PDA coronal and the axial images. We don't find any phlebolith or any component of any susceptibility, but yes, we can see cluster of clumped vascular channels which were deeply seated. Coronal image and axial image does show that it could be a vascular malformation. When we are reporting, we usually use the word slow flow vascular malformations. But the usual confusion occurs whether it is a venous type of vascular malformation or a hemangioma, which usually when it comes to be, as a radiologist, when it comes to be reported or documented. So there are some differential components which usually we are trying to assess. I showed the first image was of some vascular malformation, and I am showing you another image of similar locations with some phleboliths inside, and this is more expansite. On that note, now the differentials of VVM as well as a hemangioma usually comes in picture. There are many informations which are available about how do we differentiate, but usual standardized common practices which are there, and we usually try to apply that they usually the hemangiomas try to grow during infancy, and the vascular malformations usually are proportional to the growth of the child. So based on that, the usual differentiations which would be what? Now, based on that, the one which is expanding would be more fitting for an hemangioma because of presence of phleboliths, and the one which is more proportional to the body size of that individual would more fit in for a vascular type of malformation. This is a 42-year-old patient who had a gradually enlarging swelling over the dorsum of the forefoot. We can see on a T1 weighted image a slightly intermediate type of signal lesion, which was again extending from the plantar aspect and going into the dorsal aspect of the foot, encroaching the web spaces. This is a post-contrast image. We are seeing that the enhancement is quite intense, and the differential was a GCT. It was a radiological diagnosis also and a histopathological confirmation. Primarily, the aim of seeing that to exclude advanced sarcomatous neoplasm, and hence, although the confidence level, whatever higher it was, but histopathology was most essential for this, and it was excised. So we could confirm that it was a GCT arising from one of the plantar deep-seated tendons. Another patient, 25-year-old, occasionally painful dorsal foot mass. I would never recommend MRI for such type of pathologies. I guess ultrasound would certainly be very helpful in understanding the morphology of such cystic, well-circumscribed lesions. This is quite superficial. A probe will answer everything. A ganglion cyst, and it usually is requiring one essential element of differential is when we want to see the presence of So when we want to assess the presence of any lesion which could be of some internal heterogeneity. Ganglion cysts usually should not be having any intermediate intensity unless they are either post-traumatic or they carry some hemorrhagic debris. But the way in which this intermediate signal intensity is there, we have definitely have some documented synovial, extrasynovial sarcomas which turned out to be histopathologically. So a word of caution that contrast should always be given when there is a doubt or the intensity is not clear of such lesions. Another patient, a 49-year-old patient who had numbness over the foot, a non-fat sat image. We are not able to appreciate a pathology, but yes, closely looking at it, we can see that there is a fat intensity lesion along the medial aspect of the foot. We could see that lesion very well abutting the abductor hallucis muscle, and it is actually scalloping the margins of that. We certainly would wish to exclude such pathologies again if there is a doubt. So that turned out to be a lipoma, and there are multiple differentials or multiple etiologies which cause tarsal tunnel syndrome like pathologies. So that was a benign lipoma, but nerve sheath tumors, as we earlier saw, as well as some trauma related issues also eventually are the cause for tarsal tunnel syndrome. Another patient, triple jumper, was seen 1 month after an eversion injury. He had come in with that the plantar foot arch, whatever that arch of that foot was there, it was lost, and he was having a very much painful foot, where MR image showed a bit of partly retracted some tendons along the medial aspect as well as along the lateral aspect. This is the coronal image of that MRI. We could see that there was some marrow edema at the plantar aspects of the bases of the second and the third metatarsals. We certainly felt that there would have been some tendon injury which may have been there because of the presentation as well as he being an active sports person. So this was a patient who turned out to be having a torn peroneus tendon, which was actually attached to that level, and we could actually trace that, and the partly retracted tendon was appreciated along the lateral aspect of the midfoot region. So this is another correlative image where sometimes non-traumatic or a subtle trivial trauma will give rise to a painful os peroneum syndrome, where the sigmoid bone would be appreciated to have retracted into the lateral aspect or say inframalleolar aspect of the midfoot region. So tendon ruptures, very common and high-end, at least as Abhishek was talking about. So they're part and parcel of the high-end wear and tear of the sports person. Another patient, a gardener, a very common injury with Dr. Vaishali already showed a similar case that our occupation as well as barefoot walking certainly would be the element of history which would certainly help us to bring that or say raise a doubt on that. MR definitely is not an indicated investigation, but as we could see that there was a diagnostic dilemma, so there was a patient who was imaged like that, we could see an ill-defined, hyperintense, it was very uncertain nature and pattern type. It was partly calcified. You can see that even on the T1 as well as PD, the intensity of that lesion was not changing. And we could see that there was a track which was seen all along the plantar aspect of that foot, and we could see that the clumped calcified components, which was eventually surgically excised, and that turned out to be a foreign body granuloma. So the history as well as the pattern in which usually they are non-enhancing because they heal, they usually are showing parts of calcifications. They usually would not take up contrast, or if they are, then the surrounding tissue would be more enhancing. So that would be the important information which we can derive from MRIs. So now the patient, another patient who is a football player, sustained an hyperextension injury of the foot. This is the T1 weighted image. This is the PD fat suppressed image. The entire focus is that he was having pain along the base of the great toe, and the pain was on both sides, I mean the plantar as well as the dorsal side. This is certainly telling us that there is some element of distorted anatomy corresponding to the great toe is there. The fat suppressed image is helping us to understand that the base of the metatarsal is showing, I mean the proximal joint, MTP joint is showing edema as well as the collateral ligaments are distorted. A further axial image will help us to understand the swollen capsule as well as the partly torn or sprained collateral ligaments, which eventually would be the catch for the diagnosis. And the sagittal image definitely helps us to understand the disrupted plantar plate, and then we can see the slightly splayed sesamoid bone along the base of the proximal phalanx of the great toe. So turf toe, again, common to be seen in high-end sports person, and that would be the result of injury to either the plantar plate or that would be the injury to the collateral ligaments, which eventually would be shown up because of altered local biomechanics. There would be secondary injuries to the adjacent supporting ligaments. So these are some graphics. I guess you guys are all well versed with that, so I would not take much of that. But the entire aim was to focus on the collateral ligament as well as the intersesamoid ligaments as well as the morphology of the sesamoid bones. We can see that the tear may have been because of a repetitive microtrauma, which may have been over a period, resulting into chronic tears of such ligaments. Another patient who is a cross-country athlete has a painful forefoot. Very obvious. Abhishek already talked a lot about stress fracture. So this was the second metatarsal, which was showing a stress fracture. There was a lot of hypertrophic callus, which was there. The surrounding web space structures also had a lot of edema. And obviously, the periosteum X-ray would have been much more telling us about how the periosteum must be showing a lot of inflammatory changes. Another patient, long-standing pain in the forefoot. This is very striking image. This is the fat suppressed image. We can see that although the marrow edema is there, but the head of that second metatarsal is hyper intense, which is very classical for something which we will be terming it as a Freiberg's infraction, which eventually is a vascular necrosis happening at the head of the second metatarsal bone. Interesting case. 11-year-old kid. He had a fall 1 year back. He was managed conservatively, and there was the patient had been having that dull aching pain, and he was having a painful walk. Initially, X-ray was performed. It was showing that yes, there was a union there, but which was a bit of angulated component. There was a relative malunion, and X-ray had a doubt of that something is not very clear. So an MRI was performed. T1 sagittal and T1 the coronal images have been showing that yes, there was a fracture which has a component of healing now. But when the PD fat suppressed images were obtained, it was seen that there was an incongruent surface which had actually formed early fusion at the area where the bony component was or incongruent, and that was termed as a premature physeal closure, which had been giving up because I guess there was a malhealing. Maybe you guys would be able to enlighten me how exactly would be the mechanism. But usual, we don't expect such type of physeal premature closures happen at one focal point. So this may be the area where there may have been an injury to the direct injury to the epiphyseal plate, which may have initiated the early fusion there. If I have 5 more minutes, certainly I would be happy to talk a few more slides on ankle if you guys allow me. Abhishek, can I go ahead with 5?
You can rush through, no problem.
Yes, please. So I covered most of it. The common ones, common conditions which were seen in the foot. Now let me talk about ankle. So we usually focus on ankle ligament injuries when it comes to ankle imaging. So our aim is to identify the normal ligaments, and then how do we categorize those into respective brackets of whether it is sprain, whether it is partial tearing, or whether there are any secondary changes which will eventually give a debilitating pain to that individual in a chronic form. So our aim is usually to interpret that, and we usually try to keep our basics very simple of grading them and grading according to what you guys usually wish in terms of what are the ones which would be clinically important or which would be not very important. Too much of overcalling of a edematous ligament as a tear would not be a healthy option. So usually I try to avoid use ligament sprain. I would try to use acute interstitial injury or a partial or a full thickness depending upon that. So sprain is something which is no man's land. I guess the patient would also be having the complaints, and you guys also would not be finding it definitive answer that whether it is tear or whether it how to go ahead in that. So I would certainly restrict myself in these 4 elements. How do I describe it? And I usually use acute ligament injury and chronic ligament injury. So in that acute, I would just talk about the pattern, whether it is a stretched ligament, whether there is a discontinuity of a partial sense or a full thickness discontinuity. And when I talk about that ligament, I certainly make a point that I should stick to define whether it is tearing happening at the proximal end, mid, or the distal, because based on that, the intensity as well as the futuristic component of scarring and fibrosis would be seen in such cases. The important element is to talk about the chronic ligament injury, because this entity is definitely an entity which is a long term. The patient would be certainly coming back to you with chronic pain. So that eventually would be caused because of a scar remodeling, and that would give rise to a lot of chronic complex instability. And this is far more chronic than the actual episode of trauma to that individual. So usual stages of ligament reconstitutions, what we usually wish to see is when there would be an initial stage, we will be seeing a lot of edema. There would be a lot of hemorrhage, which would be masking a lot of ligament morphological information. And the information which would be essential is that whether it is complete thickness tear or partial thickness tear, or it is just a hemorrhage, which is all interstitial tear, what we usually say, whether it is that part. So acute phase edema is the one which usually would be not allowing us to take a definitive call. We should be definitely having a clinical call. Like you guys certainly taking a call on the stability of that joint, and based on that only, that would be a best option. But following such type of patients, we would certainly would be able to see whether that initially appearing torn ligament or say a sprained ligament is showing features of healing with discontinuity or healing without any discontinuity. And based on that, the instability, which would be a following impending thing, which would certainly be required to be defined. So healing mechanism as well as how the ligament reconstitution will happen, we eventually try to address. So usual pattern, what we see is an acute injury. Well, there would be a lot of fluid which will be leaking out from the joint, as well as the hemorrhagic components, which would still help us to identify whether there was a complete thickness tear or there was some component of connectivity in between the torn ligament bundles. When there would be a relatively mature type of injury, we eventually would see that the edema component has gone, but the connections between the proximal and the distal ends of that ligament are intact and keeping the ligament taut. So that would be a pattern which would be a partial thickness injury, and that has healed by fibrosis. Sometimes, or say the ones which have had a neglected old injury, they may sometimes form some additional tissue which we call a meniscoid soft tissue, which can be the source of instability for such patients. Lateral ligament injuries, common ones, you guys are very well aware of that. So how do I usually see them? I usually wish to see the proximal and the distal ends. And if that thing is appearing very clear to me, I would then be very sure that I'm not dealing with anything which is full thickness, and I'm just have to understand these additional surrounding structures. I am very happy to go ahead to say that it may be just a interstitial injury, and sit tight, and conservative management would be advisable. But yes, stability factor would be decided by you guys. A partial thickness tear where some fibers, deep fibers, discontinuity, I'm still seeing those for the ends around, but some deep component is discontinuous. So this will be categorized as a partial thickness. And this is obvious full thickness, where I'm seeing that the fluid is tracking all along outside that the capsule, because now there is a discontinuity of that ligament. So when it comes to acute injuries, our entire focus goes to the lateral ligament complex. And after ATFL, the CFL, which is very obviously the second ligament to get involved, I take help of coronal image, which helps me understand the ligament morphology very well. I usually take the help of the axial images to see whether the relationship between the peroneus group of tendons as well as that ligament, and how they are synergistically, how they are showing changes in each of them. And when it comes to tearing, the floaty pattern of that ligament is the helping hand which is given by the image. Sometimes the chronicity, when it is there, the ligament is not barely identifiable, but the secondary changes which are shown up by the peroneal group of tendons are the ones which help us to identify it much better way.
Can we wrap,
please? Yes, please. Last one. Yes. So the last one which I was willing to talk about was just a moment. High ankle injuries, which is, I think, the essential part for it. Just 2 slides.
Yeah.
So the high ankle injuries, which would be the anterior inferior and the posterior inferior. So these are the ones which I guess are more important when it comes to stability of the ankle joints, and that is how I try to take help of. All are better seen on an axial image. I just have to, there is nothing extraordinary which we see, only see the discontinuity and the continuity part. The most important component which we usually try to see, that whether it is associated with a syndesmotic ligament involvement, right? So that was all about the ankle. There is few more, but I guess it is beyond that time limit as well. And I tried my level best to, in a nutshell, give a little bit of whatever insight as a radiologist for an role of MRI in ankle and foot. Thank you very much.
Thanks, Bhavan. I think we actually stretched you a bit by giving you a little less time for an entire. I think there are books on written on foot and ankle MRI.
Yes, absolutely. I mean, yes, it's an important investigation. I mean, after ultrasound, I will certainly say ultrasound is the major investigation of choice. And as Dr. Sampath already told, that X-ray plays an important role. I mean, I would never undermine. I would certainly put all my money for X-ray first. And if that is not helping me, then even while I report my MRIs, I go back to see the X-rays and then take a call on that MRI. Thank you very much.
It's very important. Each one has their own roles. Each one comes up with their own strengths and weaknesses. But I think, Bhavan, thank you very much. On a short notice, you really stood up for us. And
my pleasure.
It's difficult. And I think the foot MRs that you showed were really eye-opening. MRI, ankle, I think next time we'll have you for a longer time.
Thank you. Thank you very much, sir.
Do justice to you.
Thank you, everyone.
Thank you so much, and stay there, sir. We have some questions for you. What we'll do, we have now 4 talks lined up. We have 60 minutes, but we'll see that we run on time so that we ask questions, because it was a heel topic, painful heel topic, and exercises in painful heel, they are remaining. Hope we cover in time and we ask you some questions. A quick question to you, sir. How do we differentiate on MRI if it is a Charcot joint, the destruction in Charcot joint, and unfortunately simultaneously there is infection also? So are we able to make out if this is a Charcot change or it is infection?
No. See, I will be very clear. It is like beating around the bush, if I have to talk about them, because they both have very overlapping features. And if given only one choice that I should be able to answer, that whether it is Charcot or whether it is any other thing, I would say I give up. I cannot give only one single word diagnosis for that.
Okay. Thank you so much. I will request all the speakers now. Dr. Farooq, please keep on time, and I will request you to, so that we ask you questions. And I will request Dr. Praveen Patil also to talk after Dr. Farooq. Thank you so much, Doctor. Over to you, Dr. Farooq.
Thank you so much, sir. It's a big opportunity for me to be here.
Please go ahead. Please.
So my topic is recent advances in field of physiotherapy for related to heel pain. There are many things which are coming up in the management of ankle and foot. So today we are going to see very briefly in 8 minutes about what are the treatment options available, recent treatment options available. One of the new concept which is upcoming in the field of physiotherapy is the whole body alignment. Then the second concept is the kinetic chain concepts, and then we discuss few recent machines which are available: laser, shockwave therapy, and matrix rhythmus therapy. So as we all know, our body are interconnected. All parts have some or the other effect on the adjacent joint, and since ankle and foot are the base of our joint, and if any abnormality comes here, it can affect the whole body till the neck. Same way, if there is any problem in your neck or your pelvic or hip or knee, it can affect the position of ankle also. So to correct this, first is you have to assess the alignment of pelvis, whether pelvis is aligned or not, which pelvis is in balanced position or not. Example, we can go and correct the of knee and ankle joint. So this kind of treatment, which was earlier available in a chiropractic methods, we have made a few assessment changes and we have incorporated this in a physiotherapy way. So I will brief it at the end of the talk also. Now, second is the concept of kinetic chains. You know, there are various biofacial communication lines that are the functional unit of connective tissue system available, which these are the networks which connects one body to the other part of the body, and through dissection defined lines, very defined myofascial lines which have been formed by the connective tissue system, and they play a very important role in the mobility of the muscles, mobility of the fascia, mobility of the tissue, and in fact to the extracellular levels. So if we read about the Thomas Meyer or anatomical trends, so they have defined it into a 12 myofascial meridians, which have been found. There's superficial front line, superficial back line, and see all these lines, especially the posterior lines, they have an attachment on the plantar fascia. So, and their upper attachment is on the back of the cervical, is the occiput. So, if your occiput is not aligned, is tight, if your neck muscle are tight, it can have a direct effect on your TA as well as on plantar fascia. So sometimes you may find the patient may complain along with the ankle joint, or they may have a kind of neck pain or headache also. So if you correct the whole posterior chain, I will show you the diagrams. So these are the diagrams, and especially the third or fourth one. This is a posterior myokinetic chain or posterior myofascial chain, which starts from the occiput and goes is parallel to the along the vertebral column, and then through piriformis and iliosacral ligament, it crosses to the hamstrings, then the calf, and till to the plantar fascia. So providing nutritional aspect, stability aspect, if they become tight, they can cause a mechanical problem and whole chain. So the concept which is one of the now this is not that too new. The matrix rhythmus therapy, which work on to releasing the soft tissue. Also very important. So along with the other manual or soft tissue massage, deep tissue, provide a very good tool which not only releases the fascia, which is not only releases the, in fact helps in the concept behind the matrix therapy is every cell of every tissue and every cell of the body has a specific rhythm between 8 to 12 hertz, and if any muscle, then this rhythm get up. So if you introduce this rhythm 8 to 12 hertz again, then the muscle function improves, and this helps to improve the pain and the healing. Dr.
Farooq,
yes, sir.
Dr. Farooq, you switch over your video because your internet connection is little slow, so that we can hear you clearly. You switch over your switch off your video so that your connection allows you to speak because we want to hear your good. Go ahead.
No. The second new machine which is very useful in sports injuries is a shockwave therapy. Shockwave are the high energy doses, basically pulses, which provide directly, which we give directly to the tender area or to the pain area, especially at the insertional point or at the origin point. So if a pain because of TA tendinitis, we can give to the TA tendon, or if we see there are any trigger point in the calf muscles, then we can give shockwave directly to the calf muscles. So medium we USG gel, the machine shots has to be given. So approximately to 1500 shots per muscle. So in one session I can treat up. More than that, it will cause other problems.
Don't run the videos because then we cannot hear you. You can just show the pictures because video makes your audio absolutely gone.
The connection network issue, I think.
No issues. But your talk is good. We want to see this shockwave therapy. Only thing is, don't run the videos. Then your voice is gone.
Okay. Shockwave has an excellent result in tendinitis. So whether it is about TA tendinitis or even a plantar fasciitis or like a supraspinal tendinitis, the shockwave give excellent result, and we don't require many sessions also. Like for IFT ultrasound, patient has to come for 7 days. For shockwave therapy, daily session is not needed. Patient can come for once in 3 to 4 days. Even for a chronic or acute pain, 2 to 3 sessions of shockwave are enough to deliver good results. Laser is been used since many days, but the class 4 lasers are very new. It's been in India since not more than 2 to 3 years, and now it is becoming very common of giving class 4 lasers. The advantage with class 4 laser are the penetration is quite high. So even if the muscle is deep, like piriformis or deep gluteus maximus, the rays can reach there. And not only it reduces the trigger point, it enhances the healing process also. And the effect, the laser is for short duration, 8 to 10 minutes. But the effect of laser, it keep on improving till next 10 to 12 hours. If I've given a laser for 10 minutes now, we can expect the improvement every hourly till 8 to 10 hours. There will be some improvement keep daily on a hourly basis. So laser are very good for tendinitis, for releasing the local tenderness, trigger point, releasing the tight knots, and as well as improving the healing process. Now, what we are trying to do is we are integrating many things so that we can give a best possible results to our patients. So if a patient of a heel pain or a plantar fascia or an ankle injury comes to us, we first focus on whether the alignment, the biomechanical correction is there or not. So we look up to the pelvis, we correct the pelvis, we correct the knee, and then we correct the ankle and foot. After that, we look for the tight muscles also, or fascia also, whether the hamstring is tight or quadriceps are tight or the anterior fascia is tight or posterior, or in most cases, even the IT band or a lateral fascia is tight. So we try to release the soft tissue fascia with either with the matrix or with the manual release. Or we can at home, we can give patients soft tissue roll, and even a tennis ball also helps to release the muscle and fascia. So after that, we focused on the tender part, which part is remaining. So either shockwave or laser, we give locally to reduce that local tenderness and improve the healing process locally if the tendinitis is there. And after that, we take the exercises as been shown by Dr. Pen Patil will going to take in the next topic. So after this, we started the new exercises. So what this technique, the integrated approach has done, earlier patient used to take 8 to 10 days or 2 weeks, now we are able to give results in a very shorter period of time. We don't ask the patient to come daily. We ask the patient to come once in or twice in a week, and after 2 to 3 sessions, we give a maximum results. So this is what I have to explain. If there are anything, hope I was audible and I have made my points.
Absolutely. No, this is what we wanted to see, the new tools. What we'll do, will you just unshare your screen so that we'll request Dr. Praveen Patel to see if he can share his screen, and then we'll take questions for both of you at the end of Dr. Praveen's talk, so that it will be easy for us to manage the time as well. But it was good talk. Dr. Praveen, will you just see if you can share your...
Yes, I'll try, sir.
Yeah, please. Yeah, good.
Sir, audio visible in my...
Absolutely. Go ahead.
Okay, I'll start, sir.
Yeah.
So thank you so much, Maharashtra Orthopaedic Association, for giving me topic. Today I exercises for the heel pain. I am just my topic is locating only the heel pain, that is related to plantar fascia and pure heel pains. Heel pains affect more than 50% of the Americans. The most common cause is plantar fasciitis. Repetitive motion from the running or
is it
added.
Is it the mobile from your this thing? Some mobile ring is. Yeah, please go ahead.
The most common cause is the plantar fasciitis. Repetitive moving or repetitive aerobics or added pressure from the weight gain can lead to unequal weight distribution on foot. And that leads to repetitive micro-injury or inflammations. So go through the exercises. So first exercise is toe curls with the towels. Place a small towel on the floor using involved foot. Then curl towel towards you using only your toes and then relax. This repeat for the 10 times or 1 or 2 times per day. Very simple exercises. This you can do it in the sitting. The next exercise is that is a toe extensions, or you can say the plantar fasciitis stretch. Yeah, in this exercise you will get a plantar fasciitis stretch also and calf muscles stretch also. So for how to do this, grasp the toes with the one hand and bend the toes and ankle to upwards as far as possible to stretch the arch, that is means plantar fascia and the calf muscles. So next stretch is that is the most important stretch, that is a calf muscle stretch. So we will means gastrosoleus complex we are stretching. So we are using the wall push. So in this position you have to stand in the lunge position. So basically the behind leg that will give the stretch to the calf muscle, that is gastrosoleus. For that your both foot should be perpendicular to the walls. If this is a perpendicular, you will get the good quality stretch. So next stretch, very important stretch, that is you can use the towel, yeah, you can say dupatta for giving the stretch. This is why this is most important, because every heel pains, the complaints like the pain first starts when he gets up from the bed. So before touching the foot on the ground, so you can do it this stretch, definitely the pain will be lesser. So how to do it? So use the towel, use the dupatta and just hook around your just below the toes and pull this ankle towards you, means complete dorsiflexion. Then patient will, the person will get the good quality stretch to plantar fascia and calf muscles. The next stretch, exactly, you can just use the steps. So the affected leg, just give the dorsiflexion just on the steps and just share the body weight over your heels. So you will get the good quality stretch to again plantar fascia and calf muscles. This you can do it 45 seconds, 2-3 times in a day. Repeat 2-3 times at a time. Repeat for 4 to 6 times per day. Next exercise, you can use the tennis ball or you can use the bottle. So you can fill up the bottles with the chilled water. You can say put this bottle in the freezer. So if there is inflamed fascia, also you can use that cold pack along with the roll. But you can do these exercises in the standing. So you can share the weight on the ball, or you can say that bottle, and slowly, gently roll over the that ball. So you will get the release of the fascia. So these are classic exercises for use for the heel pain, or you can say plantar fascia. And every patient we used to prescribe these exercises and ask this to patient do it religiously. But patient does religiously, but still maximum time we struggle to get the complete relief. Why? Something we are missing. What we are missing? Definitely assessment. Every patient of the heel pain is not the same. Might patient have different root cause. Let's see what is the root cause. See these 3 pictures. So posture assessment is definitely required. The first picture is the neutral pelvic, you can say normal posture. Second is the posterior tilt, and third is the anterior tilt. But let's see the foot and tibia angle. Normal first posture, you can see the tibia and foot angle around the 90 degree. And in second picture, that is the posterior tilt, you can say flat back posture. The angle is less than 90, the tibia and foot. Third picture is the that is the lordotic posture. That is there is the anterior pelvic tilt. See the tibia and foot angles. That is the angle is more than 90. That denotes, means if you have the less than 90 degree angles, means in the second picture, that means your gastrosoleus muscles, you can say soleus muscle is eccentrically loaded. And if there is an angle more than 90 degree, in the third portion, that is the gastrosoleus, you can say TA tendon is concentrically loaded. So your exercises vary with these patients. If you have the you can say eccentric loaded, and then if you are stretching the calf muscle, definitely that pain will again increase. If you have the concentrically loaded TA tendon, definitely if you are stretching the calf muscle, definitely it will help to the patients. Same like check the foot, whether the foot is pronated, you can say supinated. If the pronated foot is there, and if you are giving the ball to roll, you can say give the bottle to roll, you can focusing more to the plantar fascia release, again it will collapse down. So that will help definitely supinated foot. So in pronated foot, definitely intrinsic muscle strengthening, and you can that will help to decrease the pain. But if the supinated foot, if you are giving the intrinsic muscle strengthening, definitely it will increase the pain. So that's why the assessment is necessary to just choose these exercises. If you are randomly, if you are giving all exercise to these patients, definitely some patient will help, but some patient will not help. Same, Dr. Farooq already told about the kinetic change, but this also required because this is all the cause of your heel pain. So start maybe some pelvic problems, definitely that can lead into the pronated foot, and but still we are treating at the foot, so you will not get the result. So you have to correct from the pelvic. So give it's required stability of the pelvic. So assess the plantar fascia and soleus muscles definitely, whether it's the concentrically loaded, eccentrically loaded, and then choose exercise accordingly. So why gastrosoleus or plantar fascia is involved? So definitely kinetic change. Functional movements is walking. We usually from morning to evening we are walking. So walking, the major muscle is required the your glutes, your quadriceps, and the calf muscle, but majorly and your glute muscles. But glute muscles, if you are inactivated, you can say that is going early fatigue due to the weakness of muscles. So that walking is brought by the mainly the gastrosoleus complex, or you can say fascia, plantar fascia. So that's why that fascia is overloaded, and you land up the tight gastrosoleus, and that's because of that the pronation of the foot and the heel pain starts. So if you are focusing on the your gluteus maximus, definitely you can relieve the distresses. So major role of exercises in definitely focus on the core exercises. There are various core muscle exercises so that you can just increase strength of your transverse abdominis, multifidus, internal external obliques, along with definitely glutes. Glute also comes in your core muscles. So focus on the glutes, quadriceps, and gastro complex simultaneously. Definitely that these exercises decrease your heel pain. So key learning, detailed assessment will help to know proper cause of heel pains. It will help you to choose the correct exercises, and the proper rehab will help maximum recovery. Thank you so much.
Thank you so much, Dr. Praveen. It was absolutely appropriate talk, and even Dr. Pradeep sir also mentioned about assessing the cause of heel pain and then addressing it. And can we, shall we please unshare your screen so that we move on to next speaker, and till that time we will ask you questions to both Dr. Farooq and Dr. Praveen. Mr. Akshay, will you just share your screen?
Yes, sir. I'll do it right away.
Please. We have interesting talk now on orthotics in foot and ankle, and then Dr. Gurunath sir will talk about the pain management. Pradeep sir, any questions to Dr. Praveen who talked about particularly exercises in painful heel, and Dr. Farooq who talked about recent modalities like extracorporeal. Pradeep sir, are you there?
Yeah, I'm here.
Yeah. What is Pradeep sir? What is your talk? What is your take on this extracorporeal? When do you use extracorporeal, and when do you use core strengthening for even heel pain? What is your talk? Because
As I said, I go through the whole assessment for all heel pains, and especially I'm convinced that the patient does not have anything other than the plantar fasciitis to start with. We do send them for full physio assessment, and especially I think diagnosing patients with hamstring tightness, gastroc tightness, plantar fascia, if there's any tightness as well, or tenderness point as well. Limb length discrepancy is another thing which needs to be looked at as well. And I think once all that has been done, stretching of plantar fascia, which has been shown nicely in the previous presentation, plantar fascia stretching, calf stretching, hamstring stretching, and of course, proper posture and core strengthening. These are all the key things for patients with heel pain. I think that's very, very important and very well covered in the previous talk. Coming back to other modalities, patients probably your and my practice, we all tertiary referral patients coming through. We do get patients who have been having for 6 months, and so when somebody has then started suggesting surgery, in those patients, before I inject them, or if they've already had injected, I have a shockwave therapy machine in my clinic itself, and I advise them for going for that, to the extent now that my steroid injections for plantar fasciitis, literally, if I'm not wrong, in the last 2 years, I would have done not more than 2 or 3 cases of steroid injection. So it's almost a no-no. And I am firm believer non-invasive better than invasive. So if you do have access to it, I think shockwave therapy is a very wonderful tool in your armamentarium. It should be used if you have access to it.
Great. That is a great thought, because so many times we say that painful heel is not responding, but we fail to give physiotherapy measures properly, and that is why we listen to our two colleagues who talk exclusively on physiotherapy measures. Dr. Farooq, how are the results of laser? We heard that extracorporeal is very good for plantar fasciitis. How are the laser class 4 laser in effects in plantar fasciitis?
Sir, shockwave has better results than laser.
Good. That's good.
But sometimes, because sometimes the shockwave is quite painful. So if patient is not tolerating that, then we opt for laser.
Fantastic. So nice of you.
Can I add something for that?
Please.
The shockwave and laser, you can see if you have the inflame around the heel, and then definitely the laser therapy will help more in that time. But if you're in the chronic cases, definitely shockwave. Shockwave actually regenerate the healing process. So that gives the micro injury that area, and then enhance again healing process again. So that is the role of the shockwave therapy.
Fantastic. Thank you. We will come back to you again.
Can I just add? Can I add one thing?
Please.
The laser is quite good in reducing inflammation. While in plantar fasciitis, you don't have any inflammation. So that's why probably laser does not work. I think so. That's my thought process.
Okay. We will go on to Mr. Akshay, and then if at all there are questions, we'll take them again, because orthotics again is one important topic which helps in our conservative management. As we saw ankle sprains and other things, it is not only rest, it's the functional rehab, and orthotics play an important role. Mr. Akshay Zodge is one of the orthotists from Mumbai. Haji Ali is practicing in Mumbai. Over to you, Akshay.
Thank you very much, Dr. Patil. I am very much thankful to you to serving or allowing us to present on this platform, so that we can make aware about the field known as orthotics. So I would like to start directly with my presentation.
Please.
Why orthotics, or why orthotist rather, is a very simple answer. Basically, foot, ankle, knee and hip, all the biomechanical principles are very complex, extremely complex. It is not a rocket science, or it is actually harder to understand or to gain confidence over the experience, whatever things you do in your practice. It's a total teamwork in the part of rehabilitation when it comes to the sports injury or any kind of patient's treatment. A gait analysis is an art as well as science, comes again with the experience. In my opinion, non-specialists just cannot possibly navigate the maze successful with every patient. Orthotics should be prescribed without a throughout examination. It has to spend at least half an hour or more than in the complex cases. A certified orthotist are the professionals that I always recommend. Unfortunately, many people have never heard about them or don't know where they are the best choice or where to find them. So it's a loophole in the part of rehabilitation team. So again, starting some of the foot deformities like Achilles tendons or tendinitis, Sever's disease, heel spur, calcaneum spur, plantar fasciitis, pes planus cavis, metatarsalgia, Morton's neuroma, bunion formation due to hallux valgus, some of the neuropathic diabetic foot or hallux varus. So some of the pictorial presentation I would like to denote for this foot deformity. Starting from the hammer toe, in the neuropathic condition, it's a challenging task when it comes to the upper surface pressures by ordinary footwears. So in this, the customization plays a very major role to control scars over the hammer toes. Again, coming to the talipoequinovarus conditions, you can see on the right hand side there are different foot deformity due to the varus of valgus condition of the talipes. Again, come to the neglected CTV cases in which it's a challenging task to mobilize the case. Patients are, in these conditions, basically patients are adapted to walk on the equinovirus conditions. But again, to mobilize with the proper weight line and the gait analysis, we have to be focused as an orthotist to transfer the body weight as per required alignment. For example, if the weight is coming on the lateral aspect of the foot due to the equinovirus, then we have to consider that there should not be a torque when it comes to the footwear management. So each and every time we have to precise on the foot technician so that we can manage the angular angles required for the molded shoes in which the varus or valgus condition can be accommodated. Again, coming to the broad toe box modifications, when it comes to the hallux valgus, it's a very painful or sensitive part when it comes to the bunion formation, or patient is facing unbearable pain on the first metatarsal head. So generally we go for a broad toe box modification required in the footwear. Pes plano valgate we can see by naked eyes, in which again the body weight is again coming on the medial aspect of the foot, in which the first protocol is to transfer weight on the lateral aspect of the foot with the total surface bearing. It might be a customized insoles, or it might be a semi-rigid insoles, or it might be a rigid insoles as per the deformity or as per the protocols of the treatment in the orthotic segment. If it is a adult case, we have to think about the prevention of the deformity. And if it is a child case, then in the conservative management, whatever aspects we can achieve with the help of correcting the deformity like pes planus or pes plano valgate feet with the help of bracing technology. We will talk further over the slides. Coming to the customization into the footwear management. If the case is for the Chaco, it's again where your ankle is immobilized. We have to provide in the static gait pattern, where we have to provide a rocker sole in which patient can feel the rollover action when the ankle is immobilized. So sometimes patients are not willing to go for a pro walker or air walker, but it's a very much essential to convince patient. Is very much important to manage his ankle over the deterioration of foot deformity or progressive matters. So the molded footwear is always a bulky, it's always a keen, but again is required to prevent that deformity in coming progressing age of the patients and foot deterioration. In the podiatry solutions, again, raw materials or the whatever things we are utilizing, like if it is a neuropathy foot, we definitely will stick to the 4-way stretchable lycra based materials. We'll ask our foot technicians to footwear modifications to use a material where there will be no excessive pressure over the first metatarsals, fifth metatarsals, or over the hammer toe, which the raw materials in the broad toe box, the toe box of the footwear will expand when the foot is inserted in the footwear. Again, if it comes to the correction like cases of CTV, in the pediatric cases, we generally go for, we stick to again a rehabilitation part with the help of rehabilitation experts, like after first serial casting, then we will go for a serial splinting, and after that continuation of the Dennis Brown and the Dennis Brown splints. And again, when the child is getting mobilized, we will see to it that the deformity do not reoccur in the part of CTV. We'll again go for over corrective forefoot adduction correction shoes. So it will definitely give again a good results to achieve the correction in conservative management. Some part of bracing techniques. Initially, it was a bilateral, again, orthopedic shoes in which you might have about modifications like medial and convex border or over foot correction with valgus insoles or medial wedging and C and decrepit elongated heel. But this is again, it is a cumbersome. Patients are bound to use that particular footwear for a long time, and it has been replaced by bracing techniques right now. So we are working with supramellar orthosis in which generally pes plano valgate fit correction can be seen. In the pictorial formation, you can see with the naked eyes on the valgate feet, the weight is totally bound on the medial aspect of the foot, which is again transferred to the lateral aspect of the foot with the help of bracing. With the naked eyes from the posterior aspect, you can see the weight has been transferred to the lateral aspect of the foot, which again maintaining for or 2 years or a year, asking patient to spend at least 5 to 6 hours with proper physiotherapy and proper exercises, we can achieve a great results. We have a testimony. A child again has been not selected for the physical fitness for pilot exams, but again using supramalleolar orthosis and good therapy, he has achieved a good results and got selected again in the second attempt. So when the patient's crosses is 17 to 20 years, then we have to stick to the rigid insoles like UCBL supports, in which our main objective is to transfer weight on the lateral aspect of the foot. The correction is not the motto, but the prevention, as he has already achieved his skeletal maturity. Supramalleolar orthosis tries to lift the arches, guide heel in the proper alignment, keeps toes in the rest of the foot. Now coming to the semi-rigid insoles, in which it is used basically for the sports shoes. As Dr. Abhishek already told about surface matters when it comes to the sports activity. The same thing I would like to narrate in this fashion. Basically the footwear or the custom insoles or the raw materials involved in that particular activity is very much important when it comes to the sprinting activity, or it might be a marathon activity. So in that case, we generally focus on the semi-rigid insoles, where we can also provide toe break actions or sprinting activity where your foot is not restricted to the bracing techniques. So the process follows, and the future scope in this, like you can more think over it for the plantar surface of the foot. So I would like to discuss over the different types of analysis on which we can assess the foot in different era. So there are basically 3 analysis we go for on the foot pressure mapping or a foot mapping process, in which we allow patient to walk or to stand over the foot mapping sensor plate, on which we can see for the woman working in the kitchen for the long number of hours, how the weight line is distributed over the foot, and what is a deformity of foot. Either it might be a pes plano valgate foot, or it might be a pes cavus. What surfaces are exposed to the ground. If it is a pes cavus, whether weight is bound on the midfoot section, or it is highly exposed on the metatarsal and forefoot, so that in the neuropathy foot, we have to deload that area on the midfoot aspects. So if it is a pes cavus, we have to see that body weight is coming on the midfoot section. Either it is not creating it's loading body weight over the midfoot section. It also a concerned region or a keen region for the plantar fasciitis aspects. If it is a pes cavus, we can see a patient is always having a pain on the heel due to the high exposed metatarsals or the heel portion. So in that condition, we work on the biomechanical principle called as total surface bearing pattern, on which we try to uplift midfoot section in the custom insoles, and by filling it with the rigid cork material, which will allow to take load on the midfoot section, which will again deload the weight from the metatarsal and heel aspect. So after doing an assessment, we go for one-to-one conversation with the patients, where we can understand in which activity basically he's involved. Either he's involved in the indoor activity or he's involved in the outdoor activity. If he's a sports person, then we go for one more analysis, that is a sprinting analysis, in which what is the impact level on the forefoot. For example, one of the testimony, Madhurika Patankar, she is a badminton player, represents India, and having 5 to 6 cons on the forefoot regions, and while doing practices on the wooden bone, practice for her team. So we have seen that after using different kind of raw materials for the wooden board, especially like some of the patented raw material like Noin Poron, which has a ability to absorb this shock absorption process, in which we have seen in coming 3 months the cons has been subsided for 1 or 2 out of 6 or 5 or 6. So it is a great results when it comes to the total surface bearing of the foot from heel strike, mid stance to toe off of the gait cycle. After coming to the assessment part, after completing to the assessment part, we go for capturing impressions. See, many clinics generally go for foot scanning or foot screening basically. But after that, there is no remedy for what has to be done. Generally, people like company from the footwear like Asics or might be footwear, they already force patients to go for good footwear. Rather, I will suggest as an orthotist, a foot has to come on the total surface bearing aspect. Whatever things are there, it should be close to your plantar surface of the foot. If it is lower to the outer sole of the shoes, I don't think it is going to make any different effects when it comes to the dynamic response, higher dynamic response. So generally we go for the VVAC systems, live foot impression techniques, on which we can enroll windlass mechanism, on which we allow patients to flex his knee or to come over the forefoot, then the loading on the forefoot, then again asking patient to come on mid stance, and then again loading his weight on the heel. In this activity, we capture the total foot in the stance phase situation as well as the swing phase situation. Then again redirecting weight on the lateral aspect of the foot. If it is a pes cavus, we can incorporate the mid stance, midfoot of the impressions, and we can modify in the custom insoles.
Actually, we have to little hurry up. Huh?
Yes, sir. Again, the same concept for the non-healing ulcers, in which we have to bifurcate the programs like cons, callus, and then the ulcerization. If it is ulcer, the ortho wedge is required with the help of inner soles scoop out mechanism, so that we can get good results for the healing of the ulcers in neuropathy foots. Some of the little bit deformity in which we can provide a night splints. There are ready off-the-shelf items available to redirect the hallux valgus deformity, but sometimes patients ambulate over the splints, so they break off in the night time. So we generally go for customization for the hallux valgus correction deformity with the rigid aluminum steer bar with the correcting Velcro straps. What difference makes with the modular techniques? We, with enhanced facility with the modular techniques and rehabilitation program for the patients, in which every prosthetic and orthotic field has to be precise prescriptions. What patient benefits? It benefits with the required dynamic activities like cycling, running, driving, rock climbings. It will motivate patients to day-to-day living lives with the pain-free and swelling-free activities. So generally, customization products, the personal consultation, sometimes accidental emergency for the cervical fractures, enhanced product quality. If doctors refer to us, we see to it that goodwill has to follow for every patient after achieving success rate for that. Pocket-friendly solutions. Each and every patient cannot afford technology. So we have to work on the orthodox techniques, so which we can stick to his pocket and we can treat them. Vast experience in the field, since it is a second generation we are serving in this industry. And in-house manufacturing unit. Initially it was in Mumbai, Thane based. Right now also we are serving in Pune. A last slide, basically this is not a part of this presentation, but when it comes to the orthoprosthesis, I would like to mention your attention on this. Initially it was a capsule with filler where the limited things has to be patient's suggestions, but right now we are working on the cosmetic and cosmofunctional attention again, in which we are using a basic AFO with a partial foot with toe break actions, like you can see in the cosmetic restoration part, where patient is given with the toe break action with the carbon plates. The patient can have a great toe break resistance, in which patient can do sprinting and running activity as well on that things. So aesthetic look wise, there is a lot of scope for the female patients, and they would like to go for a whatever fancy fashionable footwear, open end footwear they can use with the this prosthetic fitments. We are also working for the microbase techniques, in which patient can transfer weight and the active dorsiflexion, plantar flexion when he thinks as per the sensors placed on the your flexors and extensors of the gastrosoleus muscles, so that we can achieve passive active dorsiflexion and plantar flexion at the time of gait cycle. I would like to, a simple thing, basically many knee deformities in the PPRP cases or knee laxity, there is a recurvatum or a valgus or varus condition. So with treating a foot and ankle management, we can correct them. In the cases of CP, basically, if is an excessive plantar flexion creating a genu recurvatum, we can definitely allow ankle to have a resistance to the dorsiflexion, but restricted to the plantar flexion, which again can correct the recurvatum things. So in CP cases, we can treat knee deformities by controlling ankle and foot deformities. That's all from my side. And once again, I would like to thank Dr. Dumbre Patil to give lending me an opportunity to make an aware about our field in this forum. Thank you. Any questions? I'm open.
Thank you so much. What we'll do is, Dr. Gurunath sir is waiting. I will ask him to share the screen. Will you stop sharing your screen so that
yes, sir.
We will have the last talk and we finish on time.
Thank you, sir.
Till he loads his talk, let me ask you a question. You very well talked about total surface bearing, and particularly to high-end athletes. Then will you recommend that they should preferably go in custom-made insoles always, because they are high-end athletes and distributing surface load over the surface is an important issue. Gurunath,
yes, sir.
Will you share your screen, sir?
Yes.
So, Akshayji, will you recommend that they should always go in custom-made insoles?
Yes, sir. Basically, when it comes to the sprinting activity or running activity, there is already a chance of mediolateral stability. So mediolateral stability is the concern. Then we can land up in the stress fractures. So if the stability is provided, definitely he is able to focus on the prospect he is due to that activity, and the ankle and foot has been taken care of by his custom insoles. So again, these custom insoles have different kinds of raw material in which toe break action is given full-fledged, and again providing a mediolateral stability with the help of reinforcement cork materials and the resins on the epoxy part.
Great. Pradeep sir, any questions or any additions? We go to the last talk then. Pradeep sir, any questions or additions, or shall we go to the last talk?
Sorry, I was on mute. Sorry. Can I just ask something? Nice talk, Dr. Zurge.
Yes,
I just wanted to ask you, what is your view on now, especially a lot of companies and a lot of physiotherapists are giving these ready-made insoles. So what is your take on it? So I'm quite a firm believer of customized insoles. So we have it at our clinic and everything. But what is your take, especially with a few new companies coming in the market?
Yeah, basically, it's like, sir, when it comes to the marketing part, so the thing is, the number of clinic is involved so that their products can be marketed directly. But when it comes to the precise practice, once the rehabilitation team has to be precise related to the rehabilitation part, so the therapist has to take over the therapist things, and the surgeons has to take the surgeons things, and an orthotist has to choose the what things the orthotist has to prescribe on the end of the requirement of that particular.
So you recommend custom made, isn't it?
Yeah, customized things always works.
Okay, thank you.
And,
So one question to Dr. Praveen and Dr. Farooq. What is the role of this shockwave therapy and matrix therapy in post-op cases, that too is foot and ankle cases?
Dr. Praveen, are you there?
Yes, I am there, sir. Definitely, the matrix therapy has the role because that matrix therapy works on the again cellular levels because the normal cellular mobility is and the same frequency we are using matrix therapy. The tight structure, means that is definitely extra particular structures. Early introduction, the matrix definitely has a good role to increase the mobility.
Okay, thank you.
Yes, sir.
Yes, sorry for joining late due to some technical problem. We had a very excellent discussion on various common foot problems, painful foot conditions by the excellent faculties, and also by the role of physiotherapy and orthotics in foot and ankle to relieve pain, to give a painless foot. So we'll just have a quick look over the what is pain and its mechanism. So as we all know, it is a very unpleasant sensory and emotional experience associated with potential tissue damage. These are the various frequency of pain in developing countries, various causes. The prevalence of chronic pain in India, various causes. The maximum is chronic severe pain, that is very degenerative pain. These are the various classifications of the pain depending on the source of the pain generator. According to the WHO, the step 1, step 2, and step 3 to what has to be used in various steps. As we all know, there are various side effects of the usual NSAIDs, renal side effects, GIT side effects, and severe side effects. So irrespective of its individual molecules and all NSAIDs known to cause the side effects of various incidents. So something about opioid analgesics, these are having morphine-like activities. According to the WHO classifications, weak opioids are the tramadol and codeine. Strongs are morphine and fentanyl. This is the analgesic main pathway, how it works on CNS system. With tramadol, it is a typical opioid dual and central acting mechanism of action. Unlike other opioids, tramadol also inhibits reuptake of serotonin and norepinephrine in the spinal cord. This is the action for the tramadol. Various modes of actions are there. If we use individually, it's tramadol is centrally acting opioid. If we use along with the paracetamol, it inhibits the cyclooxygenase in CNS system. So if we use both, then it has got synergetic analgesia. Something about neuropathic pain. The presentation is sharp shooting pain, burning or coldness, pins and needle sensations, numbness and itching. These are the various common causes of low back pain, that is disc prolapse, listhesis, canal stenosis, and spinal cord injuries. So around majority of the patients with low backache suggest presence of neuropathic or pain. So this is radicular pain, mainly in sciatica. And these are the pharmacogenic agents. It's a main action pathway. So this is in short about pain. Thank you very much.
Thank you, sir. Thank you for enlightening on the aspects of pain. It was a great session. Thank you all the faculties for sharing their thoughts. It was really a overall view of looking at the different pathologies. We discussed about physiotherapy part, orthotics part, and the orthopedic part. As a team, we give the results. So I will request Shinde sir to summarize and give his thoughts. Over to you, sir.
Thank you, Sampath. This was an excellent webinar. All faculties are expert in their field and beautifully covered all the points. Really a great session. All the webinars of foot and ankle masterclass were extraordinary. And I thank our moderator, Dr. Sampath Patil, and convener, Dr. Abhishek Kini and Dr. Gurunath Bache for their effort and excellent academics. I also thank Dr. Ashok Sham for these wonderful academic activities. On the behalf of MOA, I especially thank Maharashtra Medical Council for granting 1 credit point, and also Dr. Ravindra Shinde for being MMC observer for this today's webinar, and sponsorer Johnson & Johnson company. So friends, these were our last webinar in foot and ankle, and we are starting from next month hand and wrist, because on coming Sunday there is Dasra, so we are not going to have any activity on 25th, and next Sunday is 1st November. So since 1st November we are going to start master class of hand and wrist. Thank you very much everyone.
Thank you, sir.
Thank you, sir. Thank you, sir.
Ashok sir.
Thank you, sir.
Thank you.
Thank you everyone, and thank you Sampath sir.
Thank you.
Bye. Have a
Thank
nice
you. Thank you, Pradeep sir. Thank you, Abhishek.
Thank you, everyone. It was a nice forum.
संपत पाटील डॉक्टर, मला असं वाटतं आहे,
हो सर.
मी अभ्यास केला आता,
हो सर.
तर प्रदीप मुनोत